somebody who prostate and that bag, 3 at the bag full, urine bag full, come out. Then she start breathe properly. Dr. Cox came down and saw her and said, Gifford, you can't stay here, so we have to send it to Kingston. But come back Thursday, not to pull some more fluid because we don't want you to collapse going to Kingston. So we went, Dr. Cox, do it and head on to Kingston. Give me a letter to give it to a particular doctor in Kingston. So when we went, we asked that doctor, it's like the Magui run around. One come and say, he work with that doctor. So we said, no, we get a letter to give. So we can't give it to you. So anyway, one nurse said to me, who you want? And we tell him, we said, never letter. The nurse carry or knock on the office door. Come on. After I received the letter, he said, who named Faith? Because it was me and another lady and my wife went. So I pointed her. He said, come. He take her, he call one nurse and said, register this lady for me. But to me, I didn't think I just the water I got drought. I will come back home because we never carried it. Clothes or nothing. When the nurse go register my wife, the doctor said, come with me. I will go upstairs. And he said, Mr. Gifford, your wife has stayed here with me, you know. So, Westmoreland, if you run on a Kingston, buy Nike, buy this, buy that, buy everything. Admit her. Rush come up Westmoreland, take up some things for her and rush back to Kingston, stay me auntie. She spent 2 weeks at Chase Hospital. One Saturday morning, I can't forget. I give up because when I leave there the Friday evening and the Saturday morning when I came back, I saw 4 doctors around land. When I leave, she'd have 1 tube in her side if we pull the water. And when Saturday morning when I came back, she had 3 tubes. 2 in her nose, 1 down in throat, and 1 use and 4 doctors around her. So I said to myself, say, anytime you see a patient either go die or something going on, you see plenty doctors around them. So when we go, I just go up on the veranda and hold on on the rail. And I say, why? You're not going to leave me now. So today, stay there for a while. Then I say, no, 2 doctors leave. So I say, no, I'm the husband. So I want to know what's going on. So I went here and introduced myself to them and them said, well, Mr. Gifford, we see that your wife have a bleeding in the chest. That's that tube then push down. We say, and the 2 were inside her nose, she get oxygen. And they have to give her 2 units of blood. But I must worry myself, but I'm going to send her to KPH because if she need a surgery, that I've got done KPH. So the doctor said, okay, just send to KPH right now. Hurry up, man, and go down to KPH. And when I went down there, she came. And take her up on the ward. After she went on the ward, the doctor came to her and said to her, Miss Gifford, you're supposed to do a CT scan, but you know what I think you have to go wait till 2 weeks time because you have a lot before you. She said 2 weeks time. Anyway, Lana have the tube down her throat same way and in her nose and one side. He do so to me. After that gone and he do so to me. And I go to her and he say, so I said, what do you mean? He said, but he can't talk. So I take out my phone. And I said, if you give me phone, and I give him. And you know what Lana did? Lana takes Dr. Cox. And I went home because time to leave. So I leave. So the morning early me go, I said, Lana, hear Lana to me. So I say, what you say? He said, takes Dr. Cox. And the same doctor will come there, come tell him, say, 2 weeks time, come back and say, ready for your morning, we're going to do this. We're going to do the CT scan. So I have to give Dr. Cox thanks. She always in my wife's life, in the sickness.
I want to ask you a question, Mr. Gifford. Because this, if my memory serves me correct, you're speaking about experiences that happen in Kingston.
Yes.
But I hear Dr. Cox says that he lives in Campbellton, and then she lives in Carwin.
Right.
No, Carwin is in Westmoreland. But this looks like a whole heap every time going to the doctor in Kingston. So you were the person who had to go to Kingston with her?
Yes, sir. I don't leave her an inch. you know, I can give you one thing down here at the hospital. I take her to the hospital and she also have asthma too. And my sister bring the machine and Dr. Cox also give her the injection to put into it to help her too.
Mm-hmm.
So we take her down there one time and in her sickness when she was not going strong and rain was falling and when I reach my gate I have an umbrella and I open the car door and put her on my back. Tell her to hold the umbrella, she hold the umbrella and open the gate and go in and she get on my back and go back and open the grill and she still on my back and I take her straight home. I tell you something, I love my wife and I help her right through her sickness. So, it's an experience that I gather. And Dr. Cox also called me in the office when she was going and Dr. Cox, I'm sorry for sit there, sit right beside her. Anybody come and tell her to move, tell them, say, I'm sending you there. You sit down. And you know, the Wednesday, no, she passed the Wednesday, and I sit there with her from call about 12:30 till 1 o'clock. I tell you something, a piece of hungry bite me. And I went downstairs. But I tell me, if you move, if you stay right there. And I went downstairs. And when I went downstairs, I said, I'll get some feet and come back. I came 15 minutes after 1. And I came, the curtain dropped, and there was a doctor standing up there. So I do so. And the doctor said, who me? And I said, my wife. And the doctor said, oh, you just miss her. She just passed 10 minutes after 1. And me close her eyes. And all that. So, anyway, you see her, you see me. Doctor can't tell her. Anyway, me don't lift her an inch. She do 100 and, mind serve right, she do 100 and about 2 or 3 kilo. Doctor say never see that yet. She's strong. And the cancer start, I don't remember the year, but we know say from the breast. Doctor do a test, send it to America, it came back cancer. So doctor said, Miss Gifford, only choice you have is to remove the breast. I said to the doctor, doctor, cut off it over there. Doctor said, no, I'm not going to do that. Anyway, go on, so till she do a couple of chemo. Then she do a CT scan. Then say no cancer. Cancer gone. She was working for Mr. Williams, taking the kids to Mount up by St. Elizabeth, Hampton, and stop doing chemo. Just take 1 pill a day, but I don't think it was chemo pill. I don't remember the name of the pill.
Morphine.
Yes, morphine, right. And after that, she lived her life strong, fat, same way, everything all right, work, go on, and till one day tell me say she don't feel good. I say, what to you? But I met her around over 8, 9 years, you know, cancer free. And one day tell me say she don't feel good. So I say, what to you? He say, no. I say, then go check doctor now. Doctor check you. Went to Inagua, other doctor, you know.
No, Dr. Cox.
And Dr. Cox, they are Kingston. Dr. Cox, I call one doctor say, I want you to take care of Miss Gifford for me take my home. I tell you something. When Dr. Cox take off her breast and she in the hospital, we stand up beside her and 2 other doctors around the ward. And when they reach there, you hear one of them But I thought you saw one of us, a doctor tax patient. So, after when she tell me that she feel a little pain and we go. The cancer came into our chest. We do chemo, it remove. Then say they see one little spot on the liver. We do chemo, it move. Then say they see one little spot where the breast cut off. We do chemo, it move. Then say they see one little spot on the bone. Then say we to Kingston, our bone place, that's the only place they say do that kind of test. But I tell you something, my wife hide it from me, you know. Because she knows say me have a heart problem. She hide it from me. Anytime she do the test, she don't want me come inside anytime no test I do. And when she come back and I ask her what the result, what happened to it, she always bring up something for me and she a little thing. But you me don't want no fuss with her. You me don't want no fuss with her. Take it easy. He will carry on show Dr. Cox. And when he show Dr. Cox and Dr. Cox tell him what about, he not tell me.
Patient confidentiality.
Right. She not tell me. But she will call me sister them after and tell them. But they not tell me. And my sister them not tell me neither what's going on.
Remember the heart.
Yeah. So one day, the sister called me and said to me, say, no, let me tell you something. Anything Lana want to do, make him do it. Anywhere he want to go, make him go. So me I wonder, you know, what's happening? But then I tell me, anyway, I say, all right. Pick up myself and I carry go Canada. Then she go Canada. Christmas last year when I plane I go Canada. We spend New Year's outside Canada and come back. Lana, all right, man, Lana, jump on fire, cook and eat and one night time, you know, I think everything all right, because I touch her on her bottom and say, girl, you have put on back weight there, man. Anyway, we come back and we did it and I said to her, say, we can't go to the beach, man. And she said, go on, go to the beach and I carry her to Bluefields. Pick up my grandson. Sure, we go to Bluefields. We all swim and thing, but I notice she not that so strong like first. She have to hold on for me and go down. She come home. After she come home, she lie down, but she anything she eat, it come up back. So doctor, we call doctor said me not to give her no milk. Because I used to give her Ensure and then think about she bring it up back. So every night, because I carry Burger King staff at my night time. So every night when we come in, we turn on the light and she's on the bed and we look so upon her. But in my mind, I look, if she dead, believe me, it's true. So one night he set up for me, but me never know. So we come in, turn on the light and look upon her. So here her to me now. You think say me don't know why I look for? So I say I know you me I look upon. He say, you tell them, I know what you look for. Anyway, argument done. I turn off the light. And to be frank, she is 16. Me and she talk. We married for 26 years. And in the same period of time when she get weaker and weaker, she threw her foot on me and hugged me up and say, you know, say, I love you. And I said to her, I said, then I know you this are telling me. But it jerked me this because me I said, something wrong, man. Because if I know, she just tell me that over how much years. Something definite wrong. So she lied down and did it. Our sister came up one morning early and sometime reached my yard at 4 o'clock, 4:30, 3 o'clock sometime. And he said she hungry, but she needs some porridge. His sister said, let me make the porridge for you, man. He said, no, I don't want you to make it for me. I wake up my husband and make it. And she wake me up. But the one thing with me, I can't cook. But she did show me how to make a porridge. So, I go, make the porridge, carry it on, give her, but she had drink it here. You know, say it tastes good, but only one thing, a lumpy. But she drink it. And I find out now, say, our vice, I go away. So I say, you have to go to the hospital because, you know, I don't hear what you say, so I give him a book and a pen, anything she wants, she write it. But in my experience with my wife, more than tell every man to love their wife and treat their wife good.
We can see clearly that you love your wife. And the love that you have in your heart. The Bible says that it is in the abundance of the heart that the mouth speaks. All in your heart, you can't talk today. So I want you to tell me one thing that you really and truly miss about your life.
Well, I'm not afraid to talk the food, you know. Yes, because all when she's sick, I'm going to live a good life because I'm going to get all food in a bed.
Alright.
So, I don't have to, because it hurt my sister and it hurt me, my daughter, them with their family. Because when I go there, when them cook, I want to carry on me like, oh, my wife carry on. Them say, no, like that. They say, no, like that. They say, my wife broke my bad.
Yes. She broke your back.
Yeah.
But here what happened. We're coming back next year. And we're going to do part 2. And then off next year, the other year we're going to have part 3. And then the next year we're going to have part 4. And then the next year we're going to have part 5. So there's many other parts to tell.
Alright? Yes.
So I want to ask you, ladies and gentlemen, put your hands together for the strength and character of Mr. Gifford. And so we're going to make a presentation to him at this time.
Sister Rosie, with the mic. Turn around, turn it front side. Nobody in the foundation, Mistyblue Cancer Care Foundation, can give you the food and the throw over foot and the joke that faith gave to you, right? But one thing that we shared is the love and the friendship, because faith was everybody's friend, yeah? And so what we try to do is to capture a little moment of faith to share with you, okay? So today, we have this little token, yeah, from Mistyblue Cancer Care Foundation for you to keep it in memory of what we shared with her. So every time you look at it, you remember faith, remember us, and the friendship, and then we can do the part 2, 3, 4, 5, or whatever. God bless you. Okay.
All right, so we're going to take the sister-in-law at this time. I have 2 questions for her, so she will not be the person to talk. So, sister-in-law, please come. All right, so I want you to tell us what was the most difficult part of the journey for you caring for Faith.
Good afternoon. I did not do a lot of the caring, but I was constantly on the phone with the doctors. And there is a friend of hers, Miss Knight. She's the one who used to give me most of the information. And while she was in Kingston, I have connection with it. I'm also a registered nurse. And I got in touch with those people in Kingston. So I was getting some information which I know was not right. But I still got it. So I know exactly what was going on in her life. But I didn't tell my brother anything. I didn't want him to know, but I knew exactly what was going on.
So my final question for you.
Yeah.
How did you and the family cope? Or what strategy you used to cope after the passing of your sister-in-law?
After the passing, we just prayed. And I assure my brother that it's better for her than she's staying here and suffer. You know, we have long conversation with my brother. And I'm very close with my brother. So, and I know it was hard for him, so I was there for him.
Put your hands together, ladies and gentlemen, for the sister-in-law. We always really need our community to support those who are grieving. So at this time, I'm going to ask you to just be quiet for just a moment of silence in honor of Faith Gifford. May our soul continue to rest in peace, and God continue to give the family the strength and support that they need to journey in this life. Thank you so very much. And so, whether we believe it or not, the death of a loved one affects everybody. And so, at this time, we're going to ask the daughter-in-law to come with just her 1 minute. Give her some encouragement, ladies and gentlemen.
Good morning, everyone. Or it's afternoon. Still morning? All right, good morning, everyone. All right, so I'm definitely not a long speaker. I don't even know how it is that I'm even not shaking, because I'm normally, when I'm called to speak, I'd be shaking. Just want to share, not much, but just few experiences with Faith. Well, we call her Lorna. As in agreement with Dr. Cox, Lorna, she is such a beautiful soul. You know, I can attest to it. And like him, I couldn't have said anything at the funeral either. I know I wouldn't have been able to. You know, I was asked, but I felt as though I wouldn't have been able to carry through. But what I can say is that most persons don't have this good relationship or experience with their mother-in-law. A lot of times, persons tend to say the mother-in-law relationship is not normally good, you know, but I'm one to differ because I can say that Faith, I believe she was the best mother-in-law. You know, and the thing is, so she has 5 children, and I can tell you, so this is my handsome husband, and so regardless that, you know, he's her son, she does not, she always split things as it should be, she does not take side. You know, and she was a great mom, a super mom. She was a great friend, and I can tell you, she was just so kind. She's the sweetest soul. That lady fed me till, when I was pregnant with my son, sometimes I eat, it's like I can't even breathe. So she's good in the kitchen. She's always feeding you. Once you go where Faith is, from you go till you leave, she's just feeding you. Every time you think it's finished, she come with something else. You know, I just want to say she's a beautiful soul. I know that she's missed, you know, and I really loved and appreciated her, and also for her accepting me in her family as well. Thank you.
All right, thank you so very much. Ladies and gentlemen, that was the...
First, I want to give thanks to God. Then I want to thank, you know, the Mistyblue Foundation, you know, for putting this together, you know, for, of course, highlighting my mom. You know, unlike my stepdad, who I like to call Daddy, Uncle Rossi, you know, I'm not a long speaker. But, you know, truly, you know, my mom, you know, as everyone said, I know she, you know, was very special to us. You know, my brothers, who lives in Jamaica with me, you know, they always said I'm her favorite. But anyone who knows her knows that she doesn't have any favorite when it comes down to her children. You know, because there's nothing that she has and you ask her for it. Once she can give it to you, you know, you will definitely get it. And that's the kind of person, you know, that she was. Truly, you know, she's missed. You know, my wife, you know, back a few years ago, you know, I said to my wife I wanted to go on a diet. She said, you will never lose weight if you don't stop eating at your mom. And truly, you know, she was correct. As you can all see, you know, that's the kind of person that she was, as my wife has said, you know, she's always giving you food. But you know, I know that the time will come when I won't be able to eat from her anymore. So despite what she said, you know, I still continued eating there. You know, again, thank you, you know, for coming. Truly, it is a, you know, honor and a blessing to be here. These are my few words.
Thank you so very much. Ladies and gentlemen, that was the Faith Gifford's cancer journey. We heard from those persons who are living the lessons that they would have learned, and then it is that we heard from them through Faith Gifford, the journey that she also had. It was not one that was easy, but it was one that was filled with love. And so we move right along, ladies and gentlemen, to the Ministry of Health and Wellness address. At this time, I invite Ms. Shavel Mela to come to make this presentation. Put your hands together and make her welcome.
Hi, morning everyone. Let me just firstly say that when Dorothy invited me here today, I really wasn't expecting this.
So ladies and gentlemen, if I should just do this, this happens to be my niece. She lost her mom, which is the same sister that I lost. So I know it's difficult.
So I broke down this morning and I wasn't sure why. And I guess it was for the reason that if I came here, that was what was going to happen. But thank you so much for inviting me. I can see why we really need a community like this. I'm seeing some familiar faces who have been my community since the passing of my mom 2 months and 5 days ago, but who's counting? So let me just go through what I was invited to do. I wasn't shaking a few minutes ago, so forgive me. So good morning again, everyone. It is my distinct pleasure to bring greetings on behalf of the Western Regional Health Authority and by extension the Ministry of Health and Wellness under the stewardship of the the Honorable Minister Tufton. And to also commend the Mistyblue Cancer Care Foundation for hosting this important symposium held in loving memory of Faith Gifford. Today's event is not just a medical gathering, it is a powerful reminder of the resilience, courage, and unity that define our collective fight against breast cancer. The theme, United by Unique, captures the very essence of what makes Jamaica's healthcare landscape strong: collaboration, compassion, and commitment to improving lives. The WRHA remains steadfast in its mission to promote health and wellness through education, early detection, and comprehensive care. Breast cancer continues to be one of the most pressing health challenges among Jamaican women, and initiatives like this symposium help to ensure that awareness translates into action, saving lives and supporting families across the region. We are especially encouraged by the dedication of the medical professionals, advocates, and survivors who continue to drive this cause forward. Your efforts are building a healthcare legacy rooted in knowledge, empathy, and empowerment. On behalf of the Western Regional Health Authority, I extend heartfelt appreciation to the organizers, speakers, and participants for making this symposium possible. May today's discussions inspire continued partnerships and innovative approaches to cancer prevention and treatment. Together, let us remain united by purpose, strengthened by knowledge, and inspired by hope. Thank you.
Our theme, United by Unique. Since the foundation started 10 years ago, the Ministry of Health has been there for us. We have an endorsement, we have had support in terms of our community outreach, and you're here today. And it's not only because you're here from the ministry, but it's because of your current journey. And that is what we are here for today, because it might be a different type of cancer, it might be connection directly or indirectly, but I see your pain, and today I want you to know that our unity is strength. So, on behalf of Mistyblue Cancer Care Foundation, doesn't lessen the pain, but it shows love. God bless.
Thank you. Thank you so much.
Thank you so very much, Ms. Naylor, for representing the Ministry of Health and Wellness. And with that, ladies and gentlemen, I'm sure your bodies might be a little bit on the side that wants some refreshment. And so at this time, we're going to take a 5-minute break. 5 minutes. So we're going to go on the outside, refresh ourselves, and then return in 5 minutes. Ooh, yeah. as well. And so the Mistyblue Cancer Care Foundation, under the leadership of Dorothy Satchwell and her other committee members, thought it fit to do this symposium in her honor. And we are going to continue our lessons. So we had our first teacher this morning. Anybody remember who was the first teacher? Dr. Patrick Roberts, and he did give us food for thought. And so we're going to move right into another presentation with another teacher. So what must you take out? Our pen and our paper. And guess what happened? I command all that happens, and you see, it's a very good thing that Dr. Roberts had the first presentation, because when we're going to school after lunch, a kind of gene techie, and then so we're going to ensure that, you see, he spoke about the pianos, and he spoke about everybody, and he spoke about how we came into being as Jamaicans. We're not going to claim niggeritis right now in the name of Jesus. Alright? And so, ethnic fatigue. Alright? We're going to have now, ladies and gentlemen, Dr. Lincoln Cox, head of surgery, and I hear some hands. Oh, hold on there. No, you must follow instruction. No, Dr. Cox, sit down a little bit, sir. No, it's not yet. I recognize something. I am a math teacher by profession, so I'm very observant. But as I said, Dr. Cox, one whole set of people right over one set apart, start clapping. Now it means, therefore, that the journey with Dr. Cox is not just with Faith Gifford, but it looked like Dr. Cox journeyed one whole heap of people come up here. So, ladies and gentlemen, put your hands together and help me welcome Dr. Lincoln Cox, head of surgery at the Savannah Hospital, and he will be presenting breast cancer treatment at the Savannah Hospital.
Okay, good afternoon again. I'm pleased to be here to present at this inaugural Faith Gifford Breast Cancer Symposium. As you have heard before, Faith Gifford was special to most of us, all of us. And because breast cancer has touched all of us, even more important that we have these symposium and that we continue in the years to come. Before I start, I want to recognize, yes sir, my surgery team in the back over there, members of the Savannah General Public General Hospital. We have Dr. Reed, Dr. Duncan, we have Nurse Malcolm, Tanya Lindsay, etc., from the Savannah General Public Hospital. I'd like to take a little while to recognize our survivors. On my left, Daniel Reynolds, Debbie Ann Walters Kilburn, and Joyce Smith. Even more important to me, because they're from my little country place up in Retrieve, Cambridge, Cecile Watkins. And even more so important to me, a lady who have watched me run up and down barefoot in my community and in my brief alone, Marcia Maxwell. Very important because I ended up being their surgeons. This presentation is not as elaborate as Dr. Roberts, but we're going to begin. I think I'm going to do the presentation with Faith with me today. Okay, I just want to pause for a second. We're going to continue. The previous slides, there was a soundbite I wanted to hear because I've had many conversations with Faith, and I placed a few of the sound bites on the slide, but I don't think we're connected for audio, that's why we didn't hear it. All right, so breast cancer then. Quickly, surgery, but we're going to just talk about a little preamble. What is it? It's a proliferation of malignant cells that arise in the breast tissue, specifically in the terminal ductal lobular units of the breast. The term breast cancer represents a continuum of disease ranging from non-invasive to invasive cancer. Who gets breast cancer? Mostly women, 99% women, but yes, we have men who do have breast cancer. I remember a few years ago when I we had a media launch and we spoke about men with breast cancer, and it was shocking to a lot of people in the community. What happens if you have breast cancer and it goes untreated? Usually proliferates until the person usually demise after about 32 months. And it's a long-going study that was done many years ago. Worldwide, it's a scourge. This is the second most common malignant related cause of death amongst women worldwide. And if you look at the incidence, it's ranging from the darker areas, North America and so on. So it's a burden that affects the entire world. In Jamaica, breast cancer affects about 43 per 100,000 women yearly. And we think this is rising. As Roberts mentioned, there are tumor genes that are in our community that is supporting this rise in the incidence over the years. Mortality, significant amount of deaths. It is the #1 cause of death from cancer in Jamaica, and the second leading cause of death amongst women for for cancers worldwide. When we look at age-specific incidence of breast cancer or distribution of breast cancer across incidence over time, what we found is that, as Roberts has said, that a quarter of our patients are very young. So we have patients ranging between 20 and 49. Normally breast cancer does affect patients who are in their late 50s and early 60s worldwide, but we're finding peaks in distribution of breast cancer across Jamaica from the late 30s and 40s, and then another peak in the late 50s, and then even in the 70 to 79 age group. This goes without saying, it's a common cause of death, primary cause of death amongst women at this age, 40 to 60. The increase in incidence of breast cancer can be attributed to a number of things. One, it's a Western diet. There's alcohol, there's obesity, physical inactivity, early menarche, delayed childbearing or nulliparity, and delayed breastfeeding. Sorry. Sorry. What are some of the risk factors? Age, genetics, as Roberts talked about, which is now finding itself more prominent than anything else. Family history, increased breast density, precancerous breast lesions, and a history of irradiation of the chest. There's some modifiable factors like physical activity, alcohol, obesity, smoking, or hormone replacement therapy. We'll skip this slide, we'll talk about these already. When we look at women of reproductive age in Jamaica, we always wonder what is their risk of having breast cancer. And in our clinics, we tend to risk assess patients based on certain modifiable and non-modifiable factors that we spoke about in the previous slide. And we do attribute these to certain formulas that we can use to assess risk. Risk assessment is important because it tells us how and when we do screen patients for breast cancer. I'm not going to bore you with all these, but some of the models we use are like the Gale model, Claus model, the Thyroacoustic model. When we classify risk, we classify them in our clinic based on whether the patient is average, high, or very high risk. Very high risk patients, as we knew today, now we're talking about BRCA1, 2, and we're talking about PARB or BRCA3, where we would, perhaps if we get genetic testing, we'll be able to identify some of our patients from very, very early. The picture shows some of the crude ways we used to manage breast cancer. Many, many years ago, these guys who were in the papyrus era used to just use something like a pliers to remove the malignant edges of the breast, and hopefully the bleeding will stop. Oh, still don't get any audio, but still no audio. Okay. So how do we manage breast cancer? In 1882, William Halsted performed the first, what we call a radical mastectomy, in the era when there was a little bit of anesthesia. And he used to do a procedure where he removed the entire breast plate. It removed the breast, the underlying muscles, and sometimes in very radical, they remove the entire plate and replace it with something else. In God we trust, however, and Bernard Fisher a few years later discovered through a series of studies that we didn't have to do such a radical mastectomy. And he did describe what we call modified radical mastectomy. In God we trust still at Savlamar Hospital. This is the institution in our region that takes care of almost all of our patients with cancer in general. Because when we talk about breast cancer, that's just one. And yes, it's a huge burden, but it's one. Because we're seeing an increase in the incidence of colon cancer, prostate cancer, cancer of the stomach, and other cancers in the body, including the brain. We're seeing an increase in the incidence, and we're on the tail end of the cancer belt associated with what we call the chemical or chemical geometric cause of breast cancer. So at Savlamar Hospital is where most of our people in our population from Westmoreland, Hanover, St. Elizabeth, and so on come for breast cancer care. This is the surgery team sitting over there. Over the last 5 years, we just went back and looked at the number of mastectomies that we have done. And in 2020, we did 10, according to the books, and we had 1 mortality from it. In 2021, probably it's the height of the COVID season. I'm not so sure what happened to the statistics here, but we only had 2. In 2022, we had 13 mastectomies. But if we look to the left of this, we're seeing the number of breast surgeries alone that we have done. So we have done 13 mastectomies, but we did 37 breast surgeries with two patients who died. In 2023, we had 15 mastectomies, and all of these are modified radical mastectomies. In 2024, we have 17, and with only 2 mortality. Now, this is a series of pictures that we're going to look at, looking at the breast. So the breast, we have breast cancer that can present in a breast looking like this. There's no obvious physical change. But then we have things like this. This is a type of breast cancer called inflammatory breast cancer. And then we have this. We don't want to see this, but we see this very often now. And it speaks to what some of the aspects of what Dr. Roberts talked about your survival and your finances, and also education. This is a slide showing a series of breast cancer cases, and most of them on this slide are also advanced cancers. And in our clinic, we're finding a lot of patients presenting with advanced breast cancer. And we think that through symposiums like these and the outreach that the Mistyblue Cancer Care Foundation is doing out there in the schools and in the communities, that through education, we can reduce the incidence of late presentations of breast cancer. Okay. So apart from modified radical mastectomies, we can also do breast conservation surgery and with lumpectomy and then with mandatory radiotherapy. However, we don't have good lead times for radiotherapy that will offer most of our patients the opportunity to have conservation therapy, surgery. There are also other factors that are preventing us from doing this as well. A lot of them are patient factors, and a lot of them are factors associated with what we have at the hospital. In recent times, we have looked at through some of our residents, like Dr. Nepal, that we have looked at sentinel node biopsy, and this is a technique associated with limited surgery to the armpit, or what we call the axilla, in patients with breast cancer. So this offers us some minimal invasive treatment of the armpit in sentinel lymph node biopsy. This has been huge since 2011, when the morbidity associated with breast surgery and the dissection under the armpit caused significant morbidity. And if we could minimize the amount of surgery we do under the armpit, then would have offered the patient an increase or less morbidity. Now, breast cancer is also treated by radiation therapy. This is done at Cornwall Regional Hospital. So post-surgery, most of our patients will see the oncologist at Cornwall for continued chemotherapy and radiation therapy. There is hormonal therapy. Dr. Roberts talked about aspects of innovation in terms of hormonal therapy nowadays, or targeted therapy. But a lot of what we do with targeted therapy is also a costly venture. Chemotherapy, one of the mainstays of treatment, and I hope that as the day progresses and we talk to some of our survivors, they will help us to understand what their experience with the post-surgical care of breast cancer. I won't bother with that one. Okay, won't bother with that either. Now, in recent times, they have looked at how can we improve outcomes in patients who have breast cancer. And some of the things they look at is local management of the tumor at the time of surgery. Now, it is thought that when you do surgery and you agitate the tumor, then you perhaps increase the risk of having the patient having metastasis to other regions of the body. There's a recent study that was done that looking at infiltration of local anesthetic around the tumor at the time of surgery to help with to reduce the risk of recurrence of the cancer at the time of surgery. There should be a soundbite here as well. It's not there. All right, in SAV, pretty much in the operating theater. Again, we don't have any sound, but this is what we would do. This showing us doing a mastectomy, a modified radical mastectomy. There are there's some members of the team sitting down inside here. I see one. At the end. Would I love to hear the soundbite because he makes some interesting comments during this clip of doing a mastectomy, but because we have to watch it in silence, it's not so entertaining. So just to say, as we dissect the breast, where we just make an oval incision around it, and we basically lift it off the chest wall along with, some parts of the fibrous tissue of the muscle. And then what we do is follow the breast up onto under the armpit to dissect. There's some nodes there that we call wax and cannon that are usually there, that we want to be able to get at least 10 of those nodes so we could make a proper assessment as to the local regional spread of the tumor. Okay, so we thought about looking at this article that looked at a randomized controlled trial, a double-blind study that looked at the use of local peritumoral infiltration of local anesthetic before we do surgery. And hopefully we'll get to use this at some point at Savlamar Hospital. Okay, that's about it for my talk. Not long, and would like to thank again the organizers for allowing us to be here. And yes, we would like the sound, but still we don't have any sound, because even here we had quite a bit of, we wanted to hear the voice of Faith Gifford during the presentation. So if we could rectify it later on. Thank you. Somebody else can present now?
as you put your hands together for Dr. Cox, let I ask you to equally put your hands together for the hardworking team at the Sagamar General Public Hospital. And to see that they have journeyed here to be with us just shows how important they take their responsibilities, their duties, and their tasks. Now, for those of you who have just watched how, because we don't get the first time to go into the operating theater, just imagine the person who you send inside there to these capable hands and what happens in the process. Put your hands together again, ladies and gentlemen. We promise that we will sort out some of the audio so that we can hear, for those of you who don't know Faith Gifford, hear her voice, and to also hear some of the things that happen inside the operating theater. I think that was the part that was most interesting for me to hear.
Yeah, we wanted to hear
and that's deductive reasoning. As a mathematician, I recognize that in 2024, the number kept going up by almost 2. So 2023 was 15, 2024 was 17, and if you use deductive reasoning, we don't know what the statistics of 2025 is yet. But I hope and trust it's not 19. But we continue to labor in faith and trust God for His own work. We will now have a presentation by Dr. Everton McIntosh, consultant anesthetist at an SMO, and his presentation will be entitled Pain Management Post-Breast Surgery. Put your hands together, ladies and gentlemen, and help me welcome Dr. McIntosh.
Good afternoon, ladies and gentlemen. It's my privilege to be here to share with you on some aspects of my favorite topic, which is pain management. So my specialty includes anesthesia. So I would work with people like Dr. Cox in the operating theater, where it is my responsibility to put the patient to sleep and keep them safe throughout the procedure. But I'm also into pain management, and so I treat a lot of patients with chronic pain. And so I have altered the topic slightly, just to focus not only on the broad aspect of managing pain after breast surgery, but to concentrate on a particular complication, which is post-breast surgery pain syndrome, which in recent times has been getting more and more attention in the literature. Unfortunately, I don't have any exciting videos to share, but I hope I will still have your attention. All right. We usually like to start with a definition of pain, so everybody will have an idea of what we're talking about. Of course, if you ask everybody in this room what is pain, you'll get how many percent here? Maybe 200, not so much. What you'll get 200 different answers, because pain is a very subjective experience. But there's a formal definition put out by the showing just now. Should be showing this one. Oh, okay. But when I go to slideshow, it is not.
It should be fine. Slideshow.
So why it's not coming up on slideshow? Oh boy.
Some technical people.
It's just showing. It's not at my screen.
Sorry. But this is it comes up when he's not doing this presentation, but then it doesn't.
Right now, Commando.
No, okay. So that's look at this. It will come
Okay.
up, but then when you go in the slideshow, it just.
It doesn't. I see, but it's supposed to come up. But can you just start the presentation?
So when you go on the slideshow.
That's so strange though, because it's supposed to come over. Yeah.
You gotta click it.
Slideshow, no?
Okay. Thank you very much. All right, so let's go. All right, so pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So actual damage you can understand. So if you get a cut on your foot, you will feel the pain. But potential damage, for example, you're in the kitchen and you touch the hot stove. What happens? Ouch, and you pull away your hand. So you feel that pain, but you pull away your hand before the damage occurs. All right? So that is one of the functions of pain. It is something that warns your body that some part is subject or to actual or potential harm, so you can do something about it. Rather to prevent or to limit harm or to get cure. Pain can be classified in many different ways. One of the main ways is by the mechanism. So you have nociceptive pain, which is pain due to some form of injury or inflammation. Right? So in this case now you get the example that we just cited, you will get actual or potential tissue damage. Somatic or visceral refers. Somatic refers to your musculoskeletal system, your skin, bone, muscles, and so on. Whereas visceral refers to your internal organs. Then you have neuropathic pain, which is due to damage to neural structures, such as nerves, your brain, and so on. And this pain is because of abnormal activity developing in the injured nerve tissue. And then you have an interesting classification, it's called functional pain. Now this is kind of pain where the patient complains of pain, but there is no evidence of any injury, of any inflammation, anything. So you do all the tests you can think of, you examine the patient from head to toe, you cannot find a source for the pain. So there's no apparent tissue damage or any nervous tissue abnormality. And some examples of these include fibromyalgia syndrome. Not sure how many would have heard of that. irritable bowel syndrome, chronic fatigue syndrome, and so on, and even some headaches. And again, it can be classified according to the duration of the pain. So an acute pain, which was the example we gave a while ago, it basically warrants of an injury. So you get a hit in the head, and you feel the pain. All right. So trauma, post-operative, because really surgery is actually a type of trauma, just a controlled, deliberate trauma for the purpose of treating a condition, but it's trauma nonetheless. And then you have inflammation like appendicitis or things like that, which can induce pain. Chronic pain, on the other hand, is a situation where the pain now becomes the disease. And so it's no longer not just a warning system. So this is usually a situation where the pain persists beyond the healing phase of whatever underlying condition it is. So for example, a common situation where you're in a motor vehicle accident, you develop some kind of injury. So for example, what you call a whiplash injury, where you develop neck, back, shoulder pains. After those injuries have healed, which normally takes place maybe a week, 2 weeks, but 6 months later you're still in severe pain and it's getting worse every day. Alright, so fractures have healed, everything has healed, and the pain is still there. So that is, the pain has become chronic. It's maybe due sometimes to ongoing tissue damage, for example in cancers, or rheumatic conditions like lupus and stuff like that. And of course, as I mentioned, neuropathic pain, which is due to ongoing neural activity. So going specifically to breast surgery, this is an acute nociceptive pain. So basically, as you saw in the videos, the doctors would have cut the breast. So once you cut it, you're basically inciting trauma on the tissues, okay? But this may also have a neuropathic component because there are nerves that supply the tissues. So when they cut, the nerves are also cut. And therefore, it's likely to generate pain. And this is actually a major fear of patients before surgery. Well, not just breast surgery, any kind of surgery. One of the things people worry about is that they're going to be in pain afterwards. So some amount of pain is expected. However, with proper management, pain should be minimal. All right? And this is one of the things, as patients, you have rights. So you have the right to inquire of your doctors, your surgeon, your anesthetist, whoever is looking after you, what will be done in terms of managing your pain. How much pain are you expected to have afterwards? All right? Acute pain, however, should generally resolve once the affected area heals. And so for breast surgery, depending on the extent of surgery, usually within 1 to 3 weeks. After 3 weeks, you really shouldn't be having much pain, if any, at all. All right, so now we talk about post-breast surgery pain syndrome. So this is a situation where you have had breast surgery, and not necessarily for cancer. It can occur after any kind of breast surgeries, including what they call plastic or cosmetic surgery. So some ladies like to enhance the appearance of the breast, right? So either your breast lift or some persons may consider it's too large, so they do a reduction and stuff like that, right? But after the surgery, after the usual time period has passed where you expect the pain to go away, it persists. And sometimes the pain may actually go away, the acute pain may actually resolve, and then at some time after, could be days, weeks, months, or even years, that pain clears up again in the site where the breast was, okay? And this is not due to, so you have to make sure that this is not due to the cancer returning or an infection or something like that developing. All right? So you have to do certain tests. You may have to do x-rays or scans to rule out any form of recurrence of cancer or anything like that. Now, this was first described after mastectomy, so it was initially called post-mastectomy pain syndrome. But since we have noticed that it develops after just about any kind of breast surgery. Okay? So Dr. Cox mentioned breast conserving surgeries, breast reconstruction, and breast reduction, augmentation, and breast lift. And just about even simple lumpectomies, you can have it developing after. And it is fairly common. When you look in the literature, the figures that quoted varies widely. In some statistics, it's as much as 70%. So you can imagine 7 out of 10 persons having pain months or even years. Because this can go on for years. Sometimes it never go away after the surgery. All right? And in around 20% of cases, it is a severe kind of pain. This is a pain that's severe pain. If you, because we rate pain, there are various ways we rate pain, but a common scale is the numeric rating scale, which is a 10-point scale, where 10 is the worst pain you can imagine, and 1 is zero pain, no pain at all. So severe pain is considered to be at least 7 out of 10. All right? So 20% of persons after breast surgery will have that severe level of pain. And there may be several types of post-breast surgery pain syndrome. It can be pain in the incision, so where you had the cut, where the sutures are placed, that is the stitches, and the pain can be localized in that area. We mentioned that there may be a neuropathic component as well. Now, this is an interesting condition called chronic myofascial pain, which is a relatively recent discovery in terms of a pain syndrome, maybe in the last 30, 40 years or so. So this is a situation where the patient will develop what we refer to as myofascial trigger points. So these are tender spots that develop within the skeletal muscles and connective tissues in the affected area. All right, so we call those trigger points, and this pain can be extremely painful. All right. Phantom breast pain. Anybody has any idea what this could be? Let me see the hand. Not the doctors in the group. Don't take us. So imagine you had your breast removed, and then 6 months after, a year after, you're feeling pain in the same breast. You're feeling itching and burning and pain in the nipple, as if the breast is still there. Right? So that can be a very distressing symptom to experience. All right? And then some patients develop what is referred to as lymphedema. So because the lymphatics are something like the blood vessels that carry blood and so on, but in this case they carry a fluid called lymph, which is drained from the connective tissues. All right? So these are also, cut or destroyed during the surgery. And so the blockage that occurs causing lymph not to be able to circulate freely. And so you get swelling. It can be anywhere in the arm, around the chest, or even around the back. Okay? So that fluid building up causes pressure in the tissues and irritates the nerves. Okay, excuse me. All right, so some of the causes of post-breast surgery pain syndromes. No, interestingly, we are not really sure of the exact cause, to be honest. So these are really some suggestions, in terms of what could be causing it. The most likely scenario is damage to the sensory nerves during the surgery. So when you perform the surgery, the nerves are cut. It's inevitable that some of the small nerves are going to be cut. Remember, the breast is extensively innervated with nerves. All right, that's why it's so sensitive. All right. So when you cut the breast tissue, inevitably you're going to cut some of these nerves, leading to sometimes you get what they call a neuroma formation. A neuroma is when after the nerve has been cut and it starts to heal, it develops scarring at the end of the nerve. Okay, so it like form a bump, And this can develop and trigger abnormal nerve activity coming from it. Okay? Then there is nerve entrapment, where you have scarring, and the nerves that are in the area, they get caught up in a cord and being squeezed and compressed. Same thing happens with the contracture. And so, so this causes abnormal activity in the nerves, leading to intense pain. We already mentioned formation of myofascial trigger points, which are focal tender spots within the surrounding muscle, a condition that is referred to as chronic myofascial pain. And we also mentioned lymphedema. Now, radiation, in a lot of situations, patients will have radiation therapy and chemotherapy after breast surgery. And this can actually add to the injury at the site of treatment. So you get neuritis, myonecrosis, and fibrosis. Okay, so what are some of the risk factors? Interestingly, the younger you are, the more likely you are to develop this condition. Also, if you're obese, and then of course there are psychosocial factors, including anxiety, depression, catastrophizing, poor sleep, poor social support, and ethnicity. Now, some of these factors, for example, ethnicity, Dr. Roberts, you mentioned that one of the determining factors for how old you die is how much money you have. So the same thing applies here. In terms of ethnicity, lack of social support, and so on. These things affect your ability or your access to timely intervention in terms of care. And so, as mentioned before, we find that persons in our situation in Jamaica present late. So they present with advanced cancers. All right? And so that will tend to mean that they will have a worse outcome in terms of pain after surgery. Also, if you have pain before the operation, and it's not just pain in the breast, any kind of pain. So for example, if you had lupus, or if you have a migraine or any other kind of pain, you tend to have more severe pain after the surgery. And this has to do with activating or sensitization of your nervous system. All right? So your nervous system becomes primed, and so that painful signals entering the brain are magnified or amplified. And as a result, your post-operative pain experience tends to be more severe. Advanced breast cancer, because it tends to require more advanced, more extensive dissection, more extensive surgery, right? And so it tends to be associated with more pain. Okay? Now there are intraoperative factors during the surgery. As you just mentioned, the extent of surgery. So the more extensive the surgery is the more pain you tend to have afterwards. And that makes sense, doesn't it? Because it causes more damage. Especially axillary dissection. So Dr. Cox mentioned axillary lymph node, sentinel node biopsy. This is one of the reasons why that has developed as a technique where they do sentinel node biopsy in the axilla instead of the traditional approach, which is extensively going to remove every single lymph node there in order to catch all the cancer and to prevent it from recurring. Okay? Radical mastectomy is no longer done, I don't think. Radical mastectomy is a situation where they would remove not only the breast tissue, but they go down to the chest wall and strip out even the muscle of the chest wall. Right? So you can imagine how painful that will be afterwards. Mastectomy with reconstruction is also tend to be associated with more pain than just a simple mastectomy. And if you have, for example, if there was bleeding during the surgery, and you have accumulation of blood underneath the tissues, that tends to be a very irritating situation to the nerves, and tends to portend more pain after surgery. Post-operative factors, the most important one here is actually the severity of post-operative pain. And so it is very important that your clinical team will be very aggressive in terms of managing your post-operative pain. All right? So using a combination of techniques, including narcotics. You know, a lot of people are scared when they hear the word narcotic because it has a negative connotation in terms of addiction and so on. But that is actually the mainstay of acute post-operative pain management. All right? And we mentioned already post-operative radiation and chemotherapy as risk factors. So how do you feel if you develop, or how will you know if you're developing this syndrome? Characteristic symptoms would include burning or lancinating pain. Lancinating is a shooting type of pain, which is typical of neuropathic pains. Right? And it can occur anywhere. Right, so it can occur anywhere from the incision or the chest wall, or in the axilla, which is the armpit, shoulder, or even down the arm, or even around the back, especially if you have developed trigger points. All right? And as you mentioned again, myofascial trigger points. So you examine the patient and you find these tender spots all over in terms of the musculature. They may have also phantom pain. Right, so you're experiencing pain in the breast as if the breast is still there. Some of the other characteristic features of a neuropathic pain include numbness, paresthesia, and allodynia. Allodynia is a word that just means that a sensation which is normally not painful is painful. All right? So you go outside and the breeze blows on you, and that is extremely painful. Somebody passes and touches you, and you're jumping and say, hey, that hurts. Right? That is allodynia. Okay? You can also have muscle spasms, muscle atrophy, muscle weakness, reduced mobility of the arm or shoulder. You can't use the arm, you can't do anything. And so those are just some of the symptoms that you will experience if you are developing post-mastectomy pain syndrome. As you can understand or appreciate, it will have a significant impact on the patient and the family in terms of your psychosocial functioning. Fear, anxiety, depression, poor sleep, fatigue, loss of motivation, decreased social interactions, so you no longer enjoy going out, spending time with friends, going to church, things like that. Disruption of family dynamics. Because basically you become a burden to the family. Because you're always in pain, you're always complaining, people get tired to hear you complaining about your pain. You can't help with the housework or with the various functions in the home. You can't please your husband. All of those things. And you have persons who have actually have their marriage disintegrate because of that situation. Right? So you're not able to function as you would normally. You can't do housework, you can't go to work, and so you lose income. And of course the medical expenses add to that. And some persons become, disabled in the long term. So what are the aims of management? As with everything else, prevention is always better than cure. All right? So you want to prevent or minimize the risk of post-breast surgery syndrome. You want to relieve pain. Now, you have to face the fact that sometimes this is not achievable. Okay? And that's a fact. So there are persons, especially the ones who come with a severe condition, that the pain has become intractable. So no matter what you do, You can't go through the pain. So the focus now is not on treating or controlling the pain or getting rid of the pain, but having the patient be able to cope, to live with it. All right? And as a radio psychologist and so other members of the team come in to assist this patient in terms of coping. All right, so relieve suffering, strengthening coping mechanisms, and how we're going to help the patient to restore or maintain normal or as near normal as possible function in spite of the pain. All right, and to prevent or minimize disability. So again, we go back to the before surgery, where you want to optimize the patient's condition. So the patient who has anxiety, having anxiety, depression, and so forth, all of those things need to be treated or addressed in some way. All right. Exercise also helps. Before any kind of surgery, it's always good to get the patient as fit as possible. All right. Because persons who are fit, persons who, if they're obese, if they lose weight, they always do better in every way in terms of their recovery from surgery. And that also applies to pain. The surgical management is very important in terms of a preventing approach. So you want to minimize the degree of surgical trauma. So the choice of incision, of dissection, and so on, you want to ensure that you minimize the amount of damage that is created. So if possible, if you can identify the nerves during surgery and get around and spare them, so move them out of the way instead of cutting through them, that has been shown to help. Aggressive intraoperative and post-operative acute pain management is paramount. So there's a concept of preemptive or preventive analgesia. The idea is that you want to give pain medications effectively before the insult. So before you cut the patient, the anesthetist during surgery should have given usually some narcotics, some non-steroidal analgesics and other pain medication before, so they're actually on board at the time that the incision is made. And research is suggesting that the use of local or regional anesthesia induced before the surgical incision and maintained throughout actually has a role to reduce the amount of pain afterwards. And we use a combination of analgesics, that is what we refer to as multimodal analgesia. So we use different agents that operate at different levels of the pain cascade. And so they tend to have what's called a synergistic effect. And the aim is to have a pain score of less than 3 on a 10-point scale for this patient. So in terms of treatment approach, so of course if a patient who has had breast surgery presents, so they come back to the doctor after 3 or 4 months or 6 months, or the case may be. You can just assume that this is just post-mastectomy pain syndrome. You have to make sure that it is not something more serious, okay? Although that is serious in itself. So some of the things that you need to rule out include, you want to make sure that it's not the cancer that is recurring, if the patient had cancer as a reason for the surgery. You want to rule out an infection or some kind of traumatic injury and so on. So these are the questions they ask, and examinations and investigations to rule out these conditions. So once you have ruled those out, then you can make the diagnosis of post-breast surgery pain syndrome. Okay? It requires a comprehensive treatment strategy. So it does not matter of prescribing some painkillers until the patient come back in, a month's time or the case may be. So each patient has to be assessed and an individualized treatment plan developed. Okay? And what you want to do is, have the patient being monitored. So you're going to be seeing this patient at regular intervals, and you intervene early in terms of targeted physical, behavioral, and social, psychosocial factors to be addressed, as we mentioned before. It requires a multidisciplinary team approach, so it's not a one-man show. So sometimes this person develops pain, and then they just send them to the pain specialist, so treat this patient as you see fit. But it requires an entire team for effective management. All right? So the surgeon has a role, the pain specialist has a role, the psychologist, physiotherapist, massage therapist, even occupational therapists in some instances. All right? Rehabilitation specialists and so forth. All of those persons will have some kind of role to play in the management of these patients. All right? And very importantly, patients should be enrolled in some kind of a support group. So it always helps when there are other persons around having the same situation to deal with, then you support each other and strengthen each other. And education of the patient and the family. Education of the family is extremely important. Because sometimes the family don't understand what the patient is going through. Sometimes patients are being accused by family members as being lazy and worthless. Because they're in the house, they can't function, they can't work, they can't cook, they can't wash, right? And so people are complaining, oh, everything is left upon me. Why can't you do this? Why can't you do that? Right? And so, the family education is very important, so they understand what this person is going through and how they can assist in terms of helping them to negotiate the difficulties. All right? So there's always a role for pharmacological intervention, but we can't leave out the non-pharmacological approaches. And these are extremely important. Physiotherapy, massage therapy, well, especially those persons who may have lymphedema. So lymphedema massage and physiotherapy to get the excessive lymph to be mobilized. Stretches and what we call mobilization or range of motion exercises, especially for persons with chronic myofascial pain and trigger points. Heat, cold, tense, acupuncture, relaxation, distraction imagery. All of those things have a place in terms of non-pharmacological treatment. So in terms of pharmacological treatment, yes, we use the regular medications like your NSAIDs, paracetamol, and so on. But your neuromodulators become, they have a particularly important role in this situation because of the neuropathic component of the pain. So you have use of antidepressants like your tricyclics, your SSRIs, SNRIs, your anticonvulsants like Lyrica and gabapentin. These are the mainstay actually in terms of pharmacological management. So all of these patients will be on some kind of neuromodulators. And in addition to tramadol is very effective in these situations as well. Tramadol is actually a weak opioid and works very well for these patients. And we mentioned before that pharmacotherapy is more effective when they are used in combination to get the synergism between the different agents. And there are other agents that are used depending on specific situations, like the muscle relaxants. Persons who have a lot of burning, superficial pain, they will benefit from topical agents like capsaicin, menthol, and lidocaine. So you have lidocaine creams or lidocaine patches, which can be applied. Patients with chronic myofascial pain, and this is a significant subset of these patients. Actually, chronic myofascial pain, if I may digress just a little bit, is one of the most common causes of chronic pain. All right? So in any pain clinic or pain practice, various studies have said that up to 70% of patients who present with chronic pain actually have chronic myofascial pain with trigger points. So if you refer a patient to me for any cause, the first thing that we're going to check for is trigger points. And we find that a lot of these patients actually have trigger points that need to be managed. A lot of patients, for example, refer with arthritis in the knee. When you examine them properly, there is no arthritis. They have trigger points in the calf, in the thigh, which is referring pain to the knees. So you treat the trigger points, and the patients are fine. Okay? So in this situation, we're talking about breast pain. A lot of these patients have trigger points in the chest wall, in the shoulders, and even in the back. And so you need to search for these trigger points and you need to inactivate them. Alright? Because trigger point pain generally responds very, very poorly to regular analgesics. Right? So these patients will be put on high doses of just about everything, and the pain not budging. You have to find the trigger points and inactivate them. Okay? And these are just some of the techniques that we use to treat trigger points. Local regional nerve blocks. Again, the pain specialist will perform some of these blocks in some patients. Especially, for example, if there is phantom pain or evidence of nerve entrapment. And this may be just by infiltrating the area with local anesthetic, or you perform specific nerve blocks as indicated. As a last resort, so there are a few patients in whom you do everything, and no matter what you do, the pain not moving, right? So you have to resort to the more advanced techniques, which will include the use of narcotic analgesics. So generally, we try to avoid using narcotics for chronic pain management, because there are the concerns about addiction and so on become more important, right? But in some situations, you have no choice. The patient is suffering, and you need to get on top of the pain. Right, so in that situation, you're talking about oral morphine, or in our situation, fentanyl patch can also be used, and it has to be titrated, to the patient's condition to achieve the optimal dose or combinations. There are advanced nerve blocks that can be used with ultrasound guidance, for instance, for paravertebral blocks and stuff like that. Radiofrequency ablation, which is where a probe is inserted close to the area of where the problem is, and it applies a very fast alternating current to the area that generates heat and basically destroys the nerves in the vicinity. Okay? But usually before we do that, you'd have to perform a diagnostic block with a local anesthetic, because once you ablate that area, it becomes permanent. Right? And there can be surgical interventions as well. So sometimes the surgeon may have to go back in to excise neuromas, lysis adhesions, perform release of axillary scars, and an interesting technique. I don't know if Dr. Cox has come across in his practice, but autologous fat grafting. Because sometimes when the ear becomes extremely atrophied, what they do is they remove fat from another area of a person's body and inject it into that area just to lift the tissue up and to take the pressure off the nerves that are being squeezed or compressed. Right? And so, I think that was my last slide. All right, so basically, so what we have been recognizing is that persistent pain after breast surgery is more and more being recognized as a big problem. And so you have to have that awareness, both in the population as well as in the medical community, and so that it can be identified and the patients placed in the appropriate treatment pathway so their condition can be adequately managed and they can regain some amount of function. Thank you for your attention.
Another round of applause, ladies and gentlemen. We have been fed much food for thought, and I must thank you for not sleeping on us. But one of the things that I particularly remember from the first presentation, and I see the interconnectedness of how the medical field works to ensure that a patient gets the best care. Dr. Roberts said that he performed a surgery for 24 hours. Just imagine if they slept for 1 second in that surgery. What would have happened to our patients? It would have been my mom, your dad, your whomever it is. But they would have had to stay alert for full 24 hours. Now we are being armed with the information. We really can't stay sometimes for the full 24 hours being up, but the truth is, we're armed with information that is going to keep us alive. That's the reality of it. And so from learning of how the pain is not, many of us inside here, including me, I don't like to feel pain any at all. Let me see the hands of those persons who like to feel pain. Nobody. All right? See, look at it. Even when the light goes away, we feel pain, and look at our response. All right? So we don't like to feel pain, but pain is inevitable. But one thing I garnered from the presentation is that there is help for pain. And so if we know what it is that we ought to do, then we will be able to do so. Ladies and gentlemen, we are going to ask at this time if you have any question of Dr. Cox or Dr. McIntosh, that you can ask those questions now. We're going to take about 5 minutes into question and answer, and then we're going to ask our patient and survivor testimonies. We're taking the first two from Nicole Smart and Cecile Watkins. We'll do that immediately after we have the questions. Any questions?
Testing. Okay, this one is for you, Dr. Mack. This is a part of the experience that I had. Some observation, especially when we go into the communities, where I'll come across persons who have gone through surgeries or they have cancer. And what I have seen is it's not the physical pain, it's the fact that before surgery, that conversation wasn't had where they have an understanding and expectation of what is going to happen. I can appreciate that the intensity of pain is a personal thing, but a lot of times if I knew that I was to expect certain things to happen to me post-surgery, then the level of anxiety would have been less, where the family would have lived way up in the bush and had to travel miles to go to the doctor to be told that it is a side effect or is a process, a part of the healing process. So in addition to the, I don't know if technical is the word I want, the technical things that can be done to alleviate pain, if we look at that area where persons have the understanding that post-surgery, it is expected that this would have happened. And when we prepare patients like that, then you find that the whole psychological impact of the experience might be more tolerable. And how we develop that patient-doctor relationship so that we have that conversation. And I think that in addition to the technical stuff that we do, it is important. And especially when you have those persons who do not have the know-how to go and read and to have that understanding, that it is very important that it is explained to them so that in their language, at their level of understanding, so that anxiety is alleviated. And where do we go? How do we then have that conversation about patient care, patient-centered care, to have that understanding to alleviate the anxieties?
Yeah, that's absolutely so. And this is one of the reasons why this forum is so important, because it gives persons the awareness that they can initiate these conversations if the medical team is not forthcoming with the information. Because knowledge is power. And especially in the context of surgery, especially cancer surgery, one of the big problems is the fear of the unknown. If you don't know what is going to happen to you, fear, I use a word in one of the present slides that I did not really describe, catastrophizing. It's a situation where persons who you're not sure what to expect, and so you think the worst. Okay? You feel a little twinge and say, oh my God, I'm going to die. Okay? But if you had that conversation with your medical team who will explain everything, because you really should have it explained to you step by step by step what is going to happen, what to expect. And if you are aware what is going to happen and what you can expect and what steps will be taken to take care of you, to make you comfortable, then it had to go a long way to alleviating a lot of the anxieties and the fear associated with the surgical experience. And it have a tremendous impact on the amount of pain that you experience afterwards. Just to say, I would usually share a slide that outlines the pain pathway, the physiology of pain. But I probably should have put in one of those slides. Because what it shows is that pain is not a one-way traffic. So it's not a matter of, say, you get an injury and the signal goes to the brain. You have all kinds of signals, not just from the pain side going to the brain, but you also have signals from the brain going down. So there's a center in the spinal cord, for example, where it's operates like a gate. And so you have ascending and descending signals from the brain, from the site of injury, and they interact. And based on signals like your emotions, fear, anxiety, and so on, can influence the amount of pain that gets through to go up to the brain. All right? So if you are cheerful, you are in good spirits, then that tends to block a good amount of the pain that is going up to your brain. But if you are sad, if you are depressed, if you are fearful, then it tends to amplify the pain signal, and so you feel more pain.
Any other question?
Yeah.
All right, so I have one question. You mentioned trigger points. Is there any particular way that we can treat trigger points without having to go the route of medication?
Yeah, that's a very good question. So trigger points, all right, so what is a trigger point? A trigger point is, some books describe it as a tender nodule within a taut band. So you have a muscle which is strained or stretched beyond its normal limit, and so it reacts by tightening up, and within that area of tightness, it's like some of the fibers of the muscle are formed into a knot. Right? Actually, the layman refers to them as muscle knots. So you see persons getting massage using their shoulder and so on, and say, oh, they're working out the knots. Those are actually trigger points. So there are various ways you can treat them. One of the most effective ways is to inject them. So we call it trigger point injections. But also there are massage techniques that can be used to treat them. Where, for example, a technique that is called ischemic compression, where you apply using your finger or some tool that has a point in, not a painful point, but a focal point where you can actually apply direct pressure to the tender spot. Alright? That can be done in association with stretches and German massages, right? And so, in fact, in certain jurisdictions they have therapists who specialize in managing trigger points. And that's what they do. They will do various massaging techniques and stretches and heat, ultrasound, and so forth to treat them.
Okay. All right. So my question goes to, there are no other question? Dr. Cox? So yes, so there is a statement out in the wider world. We're asking you to tell us whether it's fact or myth, that if it is that a patient does a biopsy, then that puncture allows for the cancer to be spread readily, easily to other parts of the body.
Some aspects of that might be true. If you are going to, if you're going through body cavities, for example, and one of the common ones that we always talk about is, for example, prostate cancer. Not prostate, but pancreatic cancer. That if you're going to put a needle through the abdomen into a mass in the pancreas, something deep through the cavity of the abdomen, and then you're going to biopsy that and bring the needle out, you might see the tract of the peritoneal cavity with the tumor cells. So there's some truth to it. Biopsies, even with the breast as well, I think that the more you agitate that malignant tumor, then you might create a reaction from that tumor that will be worse than what's there before. And so even with breast cancer biopsy, we always go for a core needle biopsy or a fine needle than to try and open up the lesion to do the biopsy. I mean, one of the problems with that is that if you open an incisional or try to do an incisional biopsy, the wound itself is going to be difficult to heal if it is a malignancy. But you also run the risk of having it, spread to the rest of the breast. If it's a small lesion, you do a biopsy, they might spread it around to other areas that would have malignant tissue at the time. So yes, there's some truth to that.
All right, thank you so much. Any other question? All right, so there's a question at the back.
Is it factual that using powder can contribute to breast cancer?
Well, that has not been proven to be true, so I don't know that it contributes to breast cancer, no.
All right. One final question.
Doctor, I realized one of those pain therapy spoke to Lyrica and gabapentin. Personally, I'm familiar with both, but not, thank God it's not for cancer. But I deliberately took myself off Lyrica at the time because Lyrica sometimes provides a suicidal tendency. Is it still recommended, or there are other options?
Thank you for that question. So in a few patients, and it's actually you will actually see it in the literature when you read it, that so even some person Lyrica was actually developed as an anticonvulsant to treat fits. But it finds that in chronic pain, especially neuropathic pain, which is where it is used, in that mechanism, so that pain bears a resemblance to the electrical activity that occurs in the brain during fits, during seizures. And so it helps to suppress that abnormal electrical activity in the damaged nerves. So there are a few persons who may actually have suicidal tendencies, not a lot. It's a very small subset of persons. And so the put you on it should be something that they should warn you about. Generally, if you warn you about all the potential side effects, a more common side effect with lyric and that class of drugs is actually, neurological symptoms like sedation and dizziness and sleepiness during the day. The doctor should be in touch with you, and so that if any of that develops, then they should be made aware of it, and they can actually decide, to take you off it or what to do. Well. Yes, so it's probably used more for pain though than for fix.
Thank you so very much. So we're going to move right into our hearing from our patients. So we've heard from the medical practitioners. So now we're going to hear what has been the journey like for those persons who are still around with us. And so I'm going to invite at this time, or I may come right over to where you are, Miss Nicole. And so this is going to be my little question and answer segment with you. So we're talking this afternoon with Nicole and Cecile. All right. So my first question to you, both ladies, when you learned of your diagnosis, what was your thoughts or reactions in that moment?
Good afternoon, everyone. My first thought was death. I am dead now. That was my first thought.
Good afternoon, everyone. Thanks to Dr. Cox, who have given me the opportunity to be here this afternoon. My first thought, I was called today by Dr. Cox in the office, and actually when he called me on the phone and said to me, tell me what you're telling me on over the phone. He said, no, I have to come in the office. I went, and his office, school like this atmosphere. Now when I got the news, I had an outburst. I was hot, sweating. But what came to my mind, and I actually spoke it out loud in his hearing. I said, who am I not to have cancer? Because I'm a very much God-fearing person, spiritual, and I was surprised many weeks or months after when I realized what I said to him. I said, Dr. Cox, who am I not to have cancer? I'm not different from anyone else. I'm not exceptional. But with God, all things are possible. And he said to me, with a mindset as yours and an attitude, you'll go far away.
All right, and here you are too. All right, so what was the most surprising thing that you learned about yourself during this process?
That I was loved, very loved. I had tons of support, and it showed me that I really was loved.
Sarah said the same thing as well. I mean, I have phone numbers in my phone right now from a person who I've never spoken to on the street, but they sent and asked for my number, and that's how much I know I am loved and appreciated.
All right, so there's a wonderful community out there that supports our people. What helped you, because there are times when you're going to be in a lonely moments, and you don't want anybody around you, and sometimes nobody can be around. But what helped you to stay strong during the experience?
My son, Ben, my son, my friends. And there's a Bible verse, Isaiah 45, verse 10, I think, and it says, fear not, for I am with thee, I will uphold you. I'm not saying it exactly as it is, but I will uphold you with my right hand. And someone who was just an acquaintance heard and said it to me, and I've cherished that verse. Every time I'm like, this is the it, this is the end, I can read that Bible verse. So that and my family.
Yes, so I am here in a group, totally agreement with her. And I'm going to correct her because I am familiar with scripture, Isaiah 41, verse 10. And I do have that, and I carry it in my heart and my purse. It's a powerful scripture, and I would encourage anybody to apply that particular scripture to their lives, whether they are going through a situation or not, because the Lord, the God that we serve, He said, it's not them, he, she, or the holy. I, the Lord God, will sustain you. It is I who have kept you. I knew you before you were conceived in your mother's womb, and I know the thought that I have for you, and to give you a great end, whether you have cancer or not.
Well, as 1 verse 10 turned into in a preaching.
I must add that family is important during this time in your life. And my family, I've got the support from family and friends, and most importantly, to have the Savior with you during this time.
And so my final question to you, ladies, but we still have some other ladies that we will want to hear from. What advice will you give to someone who has just been recently diagnosed with cancer? What would you say to them?
First and foremost, I find that a lot of persons don't want to talk about it, and they don't want anyone knowing. And my view is that that is the wrong way. You will need to talk about it, and you will need support. So I would tell you, start praying, but sometimes when you're in situations, you can't pray. For me, there were times when I couldn't pray, so I said, don't tell me to pray, just pray for me. So I would want to tell you to pray first, and I'm also going to tell you to talk to somebody. It doesn't mean you're going to tell everybody what is happening, and there are times when you feel overwhelmed, so you may not want to talk about it, but talk about the sun and the moon. Let them think you're mad. It's easier a person think you're mad when you know you're really not mad. So talk, because when you bottle it up inside, it's going to push you to a limit. So you're going to talk about it, and you need support. So you prior support family, you're going to change your diet, you're going to change your whole attitude. So if you never have faith, you're going to try and develop some faith now. And you're going to tell yourself you're going to make it. You're going to do it, and you're going to work towards it, and you're going to be here.
Powerful words. Any word from Steve?
Okay, I totally agree with Paul, and it has been 6 years for Lily. And I spoke to her earlier, she said it's 12 years for her. If it had not been for the Lord on our side, where would we be today? But family again is important on this journey, and it is good to talk about it. Well, everybody has different personalities. I can only speak for myself. I'm a chatterbox, and I am not afraid nor fearful to speak about my journey. And so I'm comfortable in this platform right now to tell you about my journey. So once you can talk about it, talk about it. Most importantly, listen to your doctor, because you're going to hear a lot of things, the do's and the don'ts, what you should eat, what you shouldn't eat, what to focus, and what your doctor is saying. And if you can talk about it, talk about it. And that's just basically be comfortable. You know, I mean, it's an uncomfortable situation, but try to be as comfortable as you can. Eat, sleep. Sleep is important, because stress is what kills a lot of persons when they hear about this situation. They start stressing, their mind is all over the place. Stay focused, be centered on yourself. As for me, the day I took off my verse, I don't even look or Miss Universe or anything. I am just me, and I'm happy and proud and beautiful inside out. Not everybody will have the mindset that I say, but just stay positive, stay motivated, be encouraged, and just continue to love yourself.
Gentlemen, diagnosed, fighting and surviving. Put your hands together for Nicole Smart and Cecile Watkins. What a story, what a testimony. And so we are presenting tokens of appreciation for your stories that have encouraged you, that inspired you, that have made us into a part of the warrior field. And after 6 years, after 12 years, we pray and continue that God will continue to keep you as the apple of His eyes. So we can safely say that what the devil means for evil, God can indeed turn it into good. Indeed. We are going to move right along, ladies and gentlemen, and we have another presentation that is going to come to us. And this presentation will be done by Dr. Alcon Barnett, clinical psychologist, Western Regional Health Authority, and he will be speaking on the psychological impact of a cancer diagnosis. Put your hands together and make it work.
Good afternoon, everybody, and it's a privilege to be here among the family. So all protocols observed with special guests, and to Ms. Satchel for inviting me. I came here, I think it was last year, and it was less of medical, less of a medical presentation, but it was wonderful. So thank you for coming out, children, young people, survivors. Give the survivors a round of applause. You all know that survivorship is a task in itself. My talk really is looking at the psychosocial and the psychological impact of the cancer diagnosis. And we know that no one wants to hear the news, you have cancer. You know, worldwide, it has been devastating for many, and it brings some amount of dread, fear, anguish, pain. And at the same time, it brings with it growth. We're not going to just look at the psychosocial impact. We're going to look at some of the growth impact, what we call resilience, and how do you rise from the ashes like the phoenix. And so we're not going to be long, but I'll tie some of what I'm going to talk about with what Dr. Mack spoke about as it relates to pain. Has anyone ever seen pain? What does it look like? You feel it. All right. So you know some of what you experience as pain is psychological. The mind healer and the mind can be a slayer. And Eleanor Roosevelt, Franklin Roosevelt's wife, President of the United States, she said, "You gain strength, courage, and confidence by every experience in which you really stop to look fear in the face. And the only fear is fear itself." Who said that? Not so sure, but I'm going to ask Antoine. Give him a round of applause. Is Antoine? Give him a round of applause, everybody. In the United Kingdom, we have what we call the stress bucket. But in Jamaica, we have the baggage bucket. So Antoine is going to hold up all the baggage, although we should have used a female. Since Antoine is available. As men, we have to support our women. We have to be there for them. So one person doesn't have cancer. Cancer is the whole family. So it's the family who experience it. The family experiences trauma too. So Antoine is going to hold up the baggage right over here, Antoine. So in the baggage is financial issues, family issues, even childhood traumas. And he's going to use one hand. Now this hand is a metaphor for his brain and the stress. And so he's going to keep it out like that, but don't pay him any attention. Just if he drops him back below his waist, then he has to do 40 push-ups. So he has to keep it. So don't focus on him, focus on the presentation. Okay. So we're going to look just quickly at some psychological factors. And let's look at some stats. For example, studies indicated that neglecting mental health concerns can have far-reaching consequences. We know that for sure. And far-reaching consequences that relate to adherence. So the person might be having some mental health challenges as a result of the cancer, and they stop taking their drug, they stop coming to chemo, and they are just lost in care. They are not retained by the clinic. And some suffer and die in silence. Then we know that the prevalence of cancer-related mental health issues vary by stage. So it depends on the stage. When we're looking at diagnosis, during treatment, you have a different levels of mental health stressors. Now, common mental health challenges. Treatment issues, wait time is an issue.
I want to answer a question. Do you have insurance?
If I have one, you can't question the doctor. Back to your job.
When my man don't have money, he can't fix it.
That's all right. So, anybody have anything they can do to help him? He's going through a lot right now. Anybody have any suggestions? Who would like to come up? Oh, give Mr. a round of applause. You gave him a candy. You can't move. Back to your post. Anybody have a suggestion? What would you recommend that Antoine does now with all that stress that he's carrying?
Can't sit with him, man. He's well stressed now. Can't sit with him.
Well, what do you suggest?
Give him a chance. Let him go and sit now.
Who else? What's your name? Marissa. Come. Come. Up. Give Marissa a round of applause, everybody. She's on her way. So she believes in support. And even as medical practitioners here too, always remember self-healing, self-care. So Marissa is going to help. Let's see how she does it. Wow, unity is strength. Let us see, but you still have to stretch out for your hand just like him. Alright. Now we have recurrence. A lot of patients fear recurrence. Pay attention, don't focus on them. That's their burden to bear. Recurrence and progression is an issue. Now let us look at the normal reaction. So, well, I have this sweet. It is normal to react with shock. I notice this patient has a lot of mouth. Anyway, anybody have one more suggestion how they can handle this? It's a lot. How would you deal with his financial issues to support surgery, medication? Anybody have a suggestion for finances? Anybody suggestion for finance? You're not going to go up there, don't worry. You look like you have a suggestion with experience. Finance? Borrow some money from courts? Who else?
Get some GoFundMe.
GoFundMe? Alright. Insurance? Social intervention? What else? Good. What about support for the sleepless nights? For the pain? For the lack of disclosure that he has in his bag? Any suggestions for that? For the sleep disorders? One person stretch and shout it out. Huh? Counseling. Anybody would like to be their counselor? What? Anybody know how to counsel them? This is really a cold world. Alright, so sometimes during your toughest times in life, even your friends forsake you. And that is why social support is, and studies upon studies have shown, is one of the most powerful way to heal during your cancer journey. And so we encourage support groups, but remember, support groups are not for everyone, because you might be a alright? So, give them a round of applause. And so we have anger, irritability, and denial. I remember talking to this young lady, and she just got diagnosed. As soon as she got diagnosed, she went from bar to bar, she did about 6 different bars. And they had to pick her up in the ambulance because she was totally out of it from excessive alcohol. So she actually overdosed, became intoxicated. Then there's sadness. Is sadness normal? Yes. And so emotions will come, they will flood, but also remember emotions are normal. Emotions give the human organism data, which is information. And then we have acceptance. And so when we talk about emotions, there's no right or wrong way. No right or wrong way in And so we talk about feelings. I remember when I came and saw Antoine, and his wonderful sister was here. His sister was here, and and they're going through their pain. And she cried. And what did you say to her when she cried? Do you remember? But one of the things that's important when a person emotes or expresses emotion is to validate it. You're crying because you're sad. Is that okay? Yes. And so emotions just give you that information. The issue now is when you suppress your emotions, then you become emotionally constipated, like with the bag. And with that constipation comes more pain. So emotional pain opens the floodgates for physical pain. That's why you see sometimes they give people antidepressant for pain management. And so it can be hard to concentrate, we know that, with normal everyday things when you just find out. Some people have physical symptoms such as loss of appetite, diarrhea, difficulty sleeping. So they might have insomnia, can't sleep, or hypersomnia, sleeping too much. Even when the cock crows, they're still sleeping. Just to avoid the pain of this world, avoid different things. And so, going back to the slide where I mentioned denial, we have denial, but we also have avoidance. Avoidance is more of a behavior. You don't want to go to the clinic, while denial is a defense mechanism. So the days and weeks immediately after diagnosis can be very tough. You know, the psychological toll puts patients at risk of poor treatment adherence and outcomes. And so when you look at treatment adherence and outcomes, when you're going through a lot of emotional distress, more often than not, you will avoid the same thing that causes you the distress. So when you look at coping and treatment, coping with treatment, so handling treatment, the goal really of breast cancer treatment is to get rid of the cancer. You know that. And offer the best possible chance for survival. However, you know, common side effects come with the treatment, which brings about fatigue, you know, the common side effects, hot flashes, premenopausal issues, hair loss. And as women, most times it comes with the pangs of body image issues. My husband might not love me enough. The husband will say, I didn't sign up for this. When the person needs the help the most, some people jump ship. And so support is important. And with body image issues, you know, comes a lot of psychological issues. But just statistically looking at depression and cancer progression, 26% greater mortality with depressive symptoms, 39% greater mortality with major depression. So we know that depression can affect the person physically, psychologically, and more than likely affect the family. So we have biomarkers for pro-inflammatory cytokines are increasing in cancer patients. So even going through the stress of the cancer, you know, some people, most people become immunocompromised, and so it's harder to fight infections. You know, some of the symptoms of depression. You have insomnia, as I mentioned before, mood, feeling helpless, hopeless, worthless, feeling like you're a failure, you can't go on, you know, you feel this diminished concentration. I work with this person who just found out their diagnosis, and they was diagnosed with a depressive episode, and they would leave their keys in the bag, looking for the key under the bed, drive and park, they don't remember their cousin's name, you know, so your concentration, attention is diminished. And then there's the risk of suicide ideation, like, why live? So, depression is usually as a result of response to loss. Diagnosis of cancer feels like like mourning, it feels like grief. Like I might lose a part of my body, I might not have the same impact I have in society. And so it's a loss for most people. And how do we treat depression? We have the biological treatments, and we have medications, the SSRIs, the tricyclics, and then we also have psychological therapies that deal with behavioral therapy, for example, interpersonal therapy, and cognitive behavioral therapy. But even though we talk about depression, anxiety is more prevalent when it comes down to depression. Because we're anticipating, what if the treatment doesn't work? What if it gets worse? And so the patient can experience anxiety symptoms anticipating the future. That's a given. Anxiety can spring from the concern of reoccurrence. So even the doctor say, you're good, just come and do your checkups, or if you're on hormonal treatment, you still have those sleepless nights, worried, thinking about what if? What if? And then comes the shoulda did and shoulds. Shoulds induce guilt. Guilt is the root of depression. You shouldn't wear that hat. You shouldn't. You shouldn't have ate all those cakes. You shouldn't have smoked so much. You should have, so these things, so the should induce the depression and the what if induce the anxiety. So we know anxiety has symptoms. And anxiety is normal, it's a human response. Fight, flight. We need anxiety. Show us those who don't have anxiety. Okay, so we're all alive. So anxiety is the upstairs brain, which is the frontal lobe, the reasoning part, and then you have the amygdala, this little part in the brain, we call the animal brain, that jump when the dog is running you down. So it's the sick who laugh. Alright, so after you jump the fence and the dog run you down, after you get the cut, long after, you realize, hey, you have a cut. That is the downstairs brain telling the upstairs brain you're good now. The thing with the cancer diagnosis is that you're still in downstairs brain. You're still on the fight flight, still concerned that you might not. So it's a threat. Threat to your very survival. And so the symptoms include what? Nervousness. Anybody ever been anxious and feel your chest tighten up and run to a doctor think your heart? And your heart. But still check your heart in these. Fatigue. Some people have a severe reaction to the diagnosis that they develop a panic attack. Yeah, panic attack, meaning that they actually feel as if they're going to die. Chest tightening, breathing becomes shallow, palms sweating. And then you have some people who suppress it the whole day, when they go to bed and have a nocturnal attack. But they wake up and the thoughts start racing. And then the heart starts racing also, called it nocturnal attack, panic attack. Okay, so maintaining anxiety is we have certain issues that can happen that can maintain anxiety, and one is avoidance. The more you avoid the fear, the worse the fear gets. And so avoidance is contraindicated to understanding and recovering from intense anxiety. Muscle tension. Everybody, I want you to take a deep breath from your belly, and you're going to raise your shoulders up to your ears and just notice that tension. In, tighten, now release. You see how the muscles tense, the breathing change. You can do that as a simple anxiety relief. Just breathe in and tighten your shoulders, stretching them up to your ears. Notice that. Then let it go. So, anxiety is psycho, that means it's in your head, and it's physiological in your body. And so you take both of them. Okay, so coping with anxiety, we have different things. Everybody cope in their own way. Some use visualization to relax. I wonder if you can close your eyes if you're comfortable. Or put your neck down. And let me do a quick visualization with you. Come off your second, friends. Everybody get off your friends. Put your friends down, turn them off. I'm talking digital friends. Because they are anxiety inducers to you. Every minute you're checking for what? Notifications. Alright, close your eyes. And I want you just be aware of the weight of your body on the chair. Just notice that. Now notice your breath. Now while your eyes are closed, just imagine you're under a tree, favorite tree. It's a beautiful day. Now there's a little bird. And the bird is yellow. And notice the bird just sit beside you. Alright, open your eyes. Because I don't know, some of you have bird phobia and run out. I see some people actually didn't want to get up, you know. You went somewhere, anybody can tell me where you went?
Well, to be honest with you, I thought about everything that you said. But when you said to open your eyes, my first reaction was really to see the bird this time.
Whoa, give him a clap. He went very far out there. Now, did you know that there are physiological changes that take place in your body? And even with your neurochemicals and your hormones and cortisol, which is a stress hormone, everything, your whole nervous system just calms down. So it's important. There are so many techniques. You have Tai Chi. Tai Chi is a way to exercise and to relax your nervous system. Singing, humming. If you notice, some people deal with a lot of trauma, they hum. Humming is, they say, calm the vagus nerve, which is the longest nerve in the body. And that's why our grandmothers also used to hum. And we used to wonder, why you can't hum so? It's to stay calm, the nervous system. So singing is good. Knitting, some people do crocheting, coloring, and art therapy. All of these things are good. And you have so many apps that can help you relax. You have the Worry Box, for those who love phone. You can check out the WhatsApp Progressive Muscle Relaxation apps too, just like we were doing. Tensing, relaxing. Tense, relax. Then you have different psychotherapies as well as, for some people, anxiety might be so much that they might be in a psychiatric consultation. You said something about sex and alcohol? Go ahead. You didn't say anything about what?
I didn't say anything about sex. I asked if alcohol does come here.
Yes. The thing with alcohol helps, but it can be temporary and it can be dangerous. But so you have you have positive coping strategies and you have negative coping strategies. So there are so many things that can help. But sometimes what helps you ails you. So you need to look at the positive coping strategies. If you look at stress reduction, there's a breathing technique. We call it we call it the box breathing. Let's try the box breathing. Put one hand on your abdomen, your lower abdomen. So we all have different capacities when it comes down to breathing. Some people might not be able to breathe as deep as some, but you can put your hand on your abdomen. So when you breathe in, diaphragmatic breathing we call it, your belly goes out, so you breathe in, and when you breathe out, your belly comes back to your spine. See that? You have ever seen a baby breathe? Anybody? It's only the belly move. Stress, anxiety, and strains of this world have us breathing like we're walking around in our chest. Who would like to come and do a quick breathing technique for us? This young man, come. Oh, you're not feeling well today? Alright, who would like to come? You're a camera shy. Come. Give her a clap, everybody. Alright. Now she's going to demonstrate. What's your name?
Shanika.
Oh, thank you, Shanika. Now Shanika is going to breathe for us. And we're going to notice her belly. Now you're going to take a deep breath in, Shanika. Oh. I wonder if I know her chest moving still. In. Just so much making it. But she do a good job. Give her a round of applause. But just practice it, guys. Practice it. You can go on YouTube and see how we breathe. Sometimes when you're stressed, you can ground yourself. Even survivors or people who are supporters, just ground yourself by noticing 3 different things that you see, hear, smell. And that just move you away from that anxious feeling. Or you can do your breathing exercise, as I said before, or you can, some people are tactile, so they'll just rub their fingers on certain things, and that can ground them back to reality. So there are many ways. Some people drink something and just notice it taste in the mouth. So there are different ways to ground yourself. But one of the things that we forget though is that cancer diagnosis and treatment can result in post-trauma stress issues, meaning you have traumatic memories of procedures or just being told that you have cancer. And that's different from post-traumatic stress disorder, which is actually a disorder, it's something that needs treatment, major treatment. But, so what we have is cancer does, what is it that it does to your nervous system? So it's a highly stressful condition, it's life-threatening. And so it leads to emotional and psychological trauma. Then what is it that, what emotional and psychological trauma, what is that? What does that mean? Symptoms of post-traumatic stress at any point from diagnosis through treatment. After treatment is complete and during recurrence. And even in survivorship, there's always this fear, intense fear, what if? So, symptoms of cancer-related post-trauma stress includes one, feeling defensive. So I remember one client I had, may her soul rest in peace, she just died recently, and she hasn't been buried yet. But I remember when she came to us, she was very defensive. She was angry. She went down into her childhood. Daddy wasn't there for me, mommy wasn't there. So you have people with pre-existing psychological issues who develop cancer. So it's a double whammy for them. But she was very bitter, defensive, and she was angry with God. Why me? And going through therapy and groups was tough for her. But she came through. But over time, she avoided the chemo. The chemo was too painful. It was too much for her. And she eventually gave up. So sleeping problems is a symptom of post-trauma stress. Avoiding people, you need people. But as Doc says, sometimes you feel as if you are burdened to your family. You don't want to be around them because, I used to be so independent. Avoiding stressful memories, guilt, self-blame. So we have a thing where when you start treatment, you can develop what we call psychological conditioning. That means your mind is so conditioned to dealing with the medical procedures. For example, just triggering sounds, smells, sights of being on the ward, of being in the doctor's office can cause a trauma memory. Some people, they have to be prepared for MRI and scanners because as soon as they go into the scanner or think they're going into the scanner, they develop a serious psychological reaction. Sometimes they have to put them on anti-anxiolytics. So what happened is, for example, I have a patient who, as soon as she approached Cornwall, the gate, she started to vomit, she started to throw up, because she started thinking about the chemo. Even in some cases, you have some patients who, the day before they go to treatment, they start having reaction. They start shouting at the children in the house. They start curling up in the fetal position in their bed. So they start having reactions. And so you have to learn strategies or teach them strategies how to decondition themselves from this fear. And so one way of doing that is self-regulation, using some of the same mind-body techniques, somatic experiencing. Somatic experiencing really is learning to appreciate your body, being there with your body, not being fearful of it. And there are techniques. One technique is the butterfly technique. Everybody do like this with your hands. Do your hands like this. Put it together, two thumbs. See, it's like a butterfly. Now put it on your chest. Now alternately, one side. Just that technique in itself can be very calming. But it depends on what you say to yourself. Alright, get moving, as Dr. Max said, get moving, physical exercise. You don't have to go to the gym. Some simple walking, reconnect with old friends. You know, as a species, we are what? Social beings. Cancer will make you isolate, but it's okay. You want to be by yourself, isolation. However, to an extreme isolation can lead to rumination, repetitive thoughts, and eventually depression and severe anxiety. So for people with severe symptoms, you know, very severe, to the point where they can't function, you might need a psychiatric consult with that, combined with psychotherapy. And usually they might prescribe SSRIs, which is a serotonin reuptake inhibitors, antidepressants, or anti-anxiety, like Xanax, which, you know, you have to be careful in how these medicines are prescribed. So we have our professionals who does that. So it's fair to avoid addiction, especially the benzodiazepines. Okay, so we have a thing we call the window of tolerance, and this is how much can you manage. So if you look in the middle, right there, this is the window. This is what you can tolerate from a trauma perspective. But if too many medications, you feel overwhelmed by medication, you feel overwhelmed by the church, by people, everybody feeling sorry for you, and so you find that you might go into hyperarousal. When you're in hyperarousal, you don't want to be retained in care sometimes. You avoid clinic, you avoid going to your treatment because it's too much. It's chaotic, overwhelming, hypervigilance. Or you might go into the zone called hypoarousal, which you shut down, become numb, or freeze. In the top, on the extreme bottom, is very tough managing the fight. And so you have techniques to keep you back in the middle, grounding yourself, being psychologically flexible, thinking outside the box. Some people think rigid. Blessed are the flexible, as they'll never be bent out of shape, as I always say. If you look at the psychiatric ward, there's people who just think rigid sometimes. You have to be flexible in the thinking, do different things so you can stay in your window of tolerance. So growing out of this journey is what we call post-traumatic growth. And it's a big word, big term in survivorship now, and what it entails is, it refers to positive psychological changes that can occur following traumatic events, leading to deeper appreciation for life and stronger relationships. So a lot of people, they become stronger during the survivorship. They become more authentic to themselves. As the Bible said, adversity is our greatest teacher. And so you become stronger, you grow, you become community advocates just by going through the journey. And so another thing is emotional regulation, which we looked at, which is relaxation, breathing, grounding practices, and focusing on the present. Living in the present. What do I have now that I can use to grow and survive? Service to your community is important. Not just to the cancer community, but to your community. And so within post-traumatic growth, having breast cancer may feel like the worst thing that can happen to you. Yet, there may be some good things you can take can you control? Knowing what you can control versus what you can't. Can you control what the government is going to do tomorrow? Not necessarily. Can you control the clothes you can wear? Sometimes. Well, can you control the food? And can you control the treatment? Sometimes. So know what you can control more versus what you can't. Then self-care. You know, Jamaica have a vitamin D deficiency and yet we have so much sunshine. Take care of yourselves. Cook your food. Every now and then stay away from fast food. It's therapeutic just to stay home and cook. Take care of yourself. It's okay to help others, but love your neighbor as you love yourself. And so I want you to give yourself a hug. But here how we're going to give yourself a hug now. You're going to you come and demonstrate. Well, I have to pay him a lot of money to demonstrate. Alright, put your 2 hands in the air like this. And you can do it, you know. You can stay right here and do the same thing he's doing, but make sure your spine is straight. Everybody sit up like this. And don't fold your hand or fold your legs. Don't lock up the spirit. Don't lock up the spirit. Let it go. Put your hands in the air. You know, you want to party, not yet. Alright. So, you're going to put your right hand, no, not your right hand, whichever hand you have, you're going to put it under your arm near to your heart. So it's going to go on your left side right there. And keep your hands like this. Good. So what that indicates is that you can be gentle, forgiving, and kind to yourself. Now put your arms down like this. One in the other one was still in the air. You see that? Notice the connection, notice the warm feeling between your body and your arm. That's being kind and gentle to yourself. And this hand now is knowing that I'm not perfect, or you're not perfect. Don't put it on your shoulders, that's self-pity. Put it right here, that's love. So that's a self-hug. You see that? So do it again. I can be gentle and kind to myself, knowing that I'm not perfect. You don't have to be perfect to be kind and gentle to yourself. Alright, people.
Awesome.
Alright. Okay, so many survivors. So another thing is living in the hand, so you can be recovering from cancer, you can have a tough life, you have financial issues, and you can still take a shower, and you can still go to the park, and you can still do some artwork, and you can still fix the car engine, and you can still kiss your grandchild. And so living in the hand meaning you can live despite of. You don't live for cancer, you live through it. And you live to the fullest. And you actualize yourself. So many survivors say that breast cancer has given them a renewed appreciation for life and social network. This is a study that I did in 2019, but it was really prostate cancer, but it kind of applies here too. And what we found is a quantitative study. What we found is the men were saying trust and confidence in the medical system was one of the main obvious strategies. One man said, well, I don't think that I had a personal strategy of my own. I was just going along with the advice of the caregivers, accepting what was recommended. And so it's important for doctors and medical professionals to understand that you are important in how people go through this journey. Be gentle, be compassionate. Religion and spirituality is also important. God was my only reason for coping. My strong belief in God and His blessings brought me through. Studies upon studies have shown the power of religion and spirituality in going through this journey. And the other one was changing your mindset, what we call the growth mindset. I have accepted within myself that something would have been destroyed with that kind of treatment, but I was hoping that it would just be minimal. And so a positive mindset is good, but not toxic positivity. toxic positivity, really, what does that mean? This person over positive, that they don't care about treatment, me heal. And so, balance is the key. Yes, you have to have positive thinking, but not delusional positive thinking. And so I came up with a model, which was really for prostate cancer, but I modified it for breast cancer. And this is a holistic model. It takes a team to really fight this through. As a country, we need to invest more in medical supportive services and allied medical services. Have more psychologists to work with psycho-oncology, which is the psychology of cancer. Now that involves some amount of support actually. So we have cultural differences, not just men with women. We have the breasts removed. You have clinical management. How do you accommodate a woman who is surviving in the workplace? Do you give her reasonable accommodations? You're looking at physiotherapy, nutritionists. How are they involved? Lifestyle changes, chaplaincy for those palliative treatment care, and psychosexual intervention. Sexuality is always important in the scheme of things also. And always remember the power of the psychological, psychiatric interventions. The minute you dismiss the mental health aspect of healing, then we have a problem. And so, continue to support our survivors, ourselves, and continue to love and support the family. John 16:33. These things I have spoken to you, so that in me you may have peace. And this quote from Rumi: life is a balance of holding on and letting go. Thank you very much.
Another round of applause, ladies and gentlemen, for our presenter who energized us. And with a presentation like that, we have to do something different. So he gave us which results, so we're going to answer. So stand up for me. You have 2 feet. Stand up. Anybody who is still seated don't have 2 feet. Alright. So we're going to do some stretches. Alright, so we're going to... Alright. So we'll praise the Lord. Alright, next time. Alright, so we're going to now try to see how taller we can grow, because we're talking about growth mindset. So you're short right now. So we're going to still have our hands in the air and we're going to grow. Alright, if you have 2 feet, it means therefore you have 10 toes. Alright? Alright. So guess what? Patients follow instructions. Doctors want your feet. Do that on me too. So all the doctors in the house, it's now your time. Doctor up here and doctor down here. Alright? Yeah man, I just do that too.
Punishment, revenge.
So we're going to grow. No man, you come on. You do that to me. You know it's my time. You come to the front. So we're gonna lift first or left hand. You are doctor? Sorry, probably I should say it this way because the medical practitioners are not excuse the nurses. And then we're going to raise our right hand. So now both hands should be in the air. Now we're going to go up in the air on our 10 toes. So I don't move it. No, my dear, how much do you have? Alright, put your hands together for yourselves. You may be seated. Alright. So I'm sure after that presentation we would have some questions for Dr. Barnett. Who would want to go first? No question?
So, Doc, when I was going through my cancer treatment, one, I used to get quite anxious before chemo. So, 2 days before my treatment, I used to get, what do you call it? Massage therapy to sort of calm me down. And I've heard you spoke about other sort of things that you could do to sort of minimize the stress factor. And I like to put people on the spot. So, in terms of our care system here, unfortunately, the majority of the persons here are from low economic side of life. Where do we start to get these as part of the system, the policies that we have in our local clinics, in our hospitals, so that not only the ones who can live long because they have longer pockets can benefit, but the low pocket and empty pocket one that can live longer. How do we start that conversation? Where do we go with it? What role people like yourself, with you being a part of the system, even though not a part of the policy-making system, where do you come in to put the conversation on the table that in addition to the injection and the pill and the whatever, that these are crucial things that we need to move forward so that we can be on par with first world countries, because at the end of the day, we say we are united by unique, and people is what keep us together. So what can you do? I don't know you in person, but in terms of how do we get the conversation going so that we can look towards more people-centered cancer care in Jamaica, in Westmoreland?
Okay, thank you for that question. So, the thing is, it starts with us, even right here. So you don't have to be a millionaire, you don't have to be pocket, you don't have to belong to start advocacy. And advocacy can start with your local representative from the health standpoint, from the Ministry of Health standpoint. It can also start with clinic, groups, writing and sharing and expressing what you think are the important factors that will contribute to a holistic cancer care. Because we have done that with HIV, and we have done it with, to a small extent, with lupus. So, with cancer care, we can start with yourselves in little groups. Remember, the group is the power. Group is power. From my standpoint, I've always advocated for health psychology and psycho-oncology in different facets. The HIV program is like a standard bearer for that kind of holistic approach. And we want to see it amalgamated in the full framework of cancer care. So it can start with the Chaplain Institute, where when you go to your group sessions or recovery sessions, you put it to the chaplain to advocate for Ministry of Health. And the good thing is, the Ministry of Health has started the compassionate care programs, and I've seen where Dr. Tufton has spoken about the whole holistic aspect of NCDs, like high blood pressure, diabetes. Why not include cancer? So we got to advocate for cancer holistic care. Having a psychologist, a social worker, not just a medical social worker from the hospital, but a social worker directly employed to the oncology unit. I don't see that being a hard thing. So I think we need to start with our local organizations to advocate for this. Because cancer is mind, body, spirit. And that's how we need to approach it. Thank you.
arms, the mind, the body. And so we want to thank you so much for your presentation, Dr. Barnett. Once more, put your hands together for Dr. Barnett. And so we're going to go now to another two of our patient and survivor testimonies. So at this time, we're going to invite Joyce Smith, all right, and Marcia Maxwell, all right. So let me get the right on over here. So my first question to you is, how long have you been surviving as a breast cancer patient?
4 years.
All right. So let me ask you to say that again for the audience.
4 years since I have done my surgery.
So 4 years. All right. How long have you been diagnosed and surviving as a patient? So we have 4 years, ladies and gentlemen, and we have 5 months. Put your hands together for them. Each day alive is a blessing, and so we're going to celebrate that. How do you feel? Though you have cancer, be honest with me. How do you feel?
I am feeling okay because it's a family history. So I try to cope with it the best way I can.
Alright, that's a good way to put it. It's a family history. I try to cope with it the best way I can. How do you cope with it?
Mine is not a family history, but I'm trying to cope with it. With my families, and pastors and church sisters is giving me encouragement. So I'm trying to cope as I can.
Alright. With this new diagnosis that you have, how has that changed your perspective on life?
Well, I would say I don't see any struggling with my changes of life because I go about doing things same as I have been before. I go to the market, I do my housework, I go to the bush, I do everything. Go to church, and I feel as comfortable as I am.
Right. How about you? How do you feel? What is your perspective now that you have been diagnosed with cancer?
Well, my first is I try not to worry about my sickness, as I said. It is a family history. When I find myself in any difficulty, I live alone, and she's my daughter-in-law. Whenever times I feel depressed, I would walk my journey to her room. And here, we sit and we talk. When I was diagnosed with this thing, I went to the Cambridge Health Center. And I went to the Cambridge Health Center. The doctor said I should go on the bed. I went on the bed and she tested me or put my hands all different ways. She said to me it was nothing for me to worry about. So I was up and down, moving around until I feel the breast started to pain me. And then I tell my daughter-in-law, and she said I should go to the doctor. And I said to her, why should I go back to the doctor? And the doctor said, it's nothing for me to worry about. Anyway, she insisted on me, and I went to Dr. Cox, and Dr. Cox sent me to do the test, and the test came back, and in April 2021, I
Dr. Cox removed the breast. And here I am, giving God thanks to taking me through my journey.
I see you laugh just now, and a scripture came to my mind. The joy of the Lord is our strength. And so as we smile about it, even in the pain, we can truly remember that God is there with us to comfort us. Now, since as you are young, and I mean, you take it so forceful, you say that you don't change your life, you got to push, you got to mark it, do everything. How important is it then to keep yourself active and occupied, to not cause your mind to be thinking about this diagnosis that you have?
I try to know that it is there already, and the most thing, my life is here, and I feel strong. I don't feel any way sick or other. And I have my daughter to encourage me, who is in the health sector. And she encouraged me a lot, tell me what I must eat or drink and whatsoever. And is there I am here. Try to live in faith and in God. Try to hold on until it's time for me to live this place.
Yes, amen.
Amen.
See, God is in control, and when you can testify that you are only here because of Him, then it is more than solid faith, ladies and gentlemen. It is more than a testimony. It is only God's enabling grace and mercy. And my encouragement to you as you continue is to allow Him. He says He promises never to leave you nor forsake you, and will never allow your seed to beg any bread. Not for you. Because you look nice. I look nicer than me. You look nicer than me? What would you say to somebody if they should walk up to you today and ask you, I am diagnosed with cancer, what should I do? What would you tell the person?
I would say to that person, just leave everything in the Lord's hand. Because Scripture has it said, I will lift up my eyes unto the hills from whence cometh my help. My help cometh from the Lord, which made heaven and earth. And He take not only one person through our problem, or He will see every one of us through.
Right, and so He will see each of us through, irrespective of our circumstances. And Psalm 91 tells us that he that dwelleth in the secret place of the Most High shall abide under the shadow of the Almighty. Let us say amen to that, ladies and gentlemen. Amen. And so we have one final presentation. But just before we get into that presentation, we will make tokens of appreciation to our dear Joyce and Marcia. We thank you for sharing your story with us, to inspire us and to encourage us that no matter what comes our way, God will see us through. Another round of applause, ladies and gentlemen. And with that, we invite Mr. Walter Dunbar, psychologist, to come to make presentation on the impact of cultural beliefs and norms on a cancer diagnosis. Help me welcome him, ladies and gentlemen.
Good afternoon, ladies and gentlemen. I want to thank you for having me here. Please do not pay attention to my speech. But I welcome my colleague, Mrs. Roberts, to assist me so we can go in. We would have had a long day, and I know that a lot of us are ready to sleep, and a lot of us would rather now be at home than here. But as is said, it is the final presentation, and as such we are going to do an activity, so I am asking you to give us your time. Thank you.
Good afternoon, everyone.
Good afternoon.
All right, I'm going to ask you to take out your phones. Now you must be wondering, why should I take out my phone? I want for you to take a picture of yourself.
Oh my God.
Selfie. Take a photo of you. I'm going to give you a minute. We're supposed to have some music, but we have some technical difficulties. We're taking the photos? Hold on, let me get my phone too. Hold on. Right. So we have the photos, right? Need some more time for that? One to take. That's a photo shoot. Alright. Now I want you to take just 10 seconds to look at that photo.
Oh my God.
Now I'm going to walk around the room, probably about 5 responses, if you want to, not forcing anybody, to tell me what do you see in that photo.
Oh my God.
So I want to start. Any volunteers? Come in. What a beautiful lady.
I feel blessed and highly favored.
I can see that. Thank you for sharing. Anybody else? I come in exercise. Alright.
I am seeing visibilities of exhaustion, but I am also seeing some happiness and joy for being here.
Thank you for sharing. Alright, now I want you to, one more. Hold on. I tell you what I see on your photo. That looks like a different photo. Alright.
As she's suffering.
But I don't see that when I look at it. What you see, right? I'm not feeling that no one is what you feel suffering. Alright, so you see. Okay. I empathize with you. I'm really sorry. But I'm happy that you're here today. And you're in the present. And that makes you a brave man. And I want to be here to empower you. Alright? you to just to honor the warrior in you. There's a warrior in everybody, you know. So honor the warrior in you. All right? Thank you, ladies and gentlemen.
Thank you very much, Mrs. Roberts. So we are going to go into the impact of cultural beliefs and norms on a cancer diagnosis. We are going to look at understanding how culture shapes perceptions, care, and outcomes. You would have already known who we are. So we are representing the Jamaica Psychological Society, Western Region. All right, so cancer is not only a medical condition, but also a social and cultural experience. We get the diagnosis, we would have heard from the respective individuals inside here. You get the diagnosis, what next? You go home, and it's a totally different story. You have either side of the spectrum. Is either you're going to share, this is what is happening with me, and the family either rally around you, or you choose not to share. Unfortunately, there are cases where people hide their diagnosis until the day they die. And the family is left with that assumption that it was just a regular illness, which brings me to now my question. By a raise of hands, show me the persons when you were growing up, you only knew about high blood pressure as a sickness. You only know that there was cancer, but there were no specifications of cancer. It's just somebody have cancer and them dead. By a raise of hands. By a raise of hands, show me if you thought that sugar and diabetes were two separate things. Because that is really and truly the culture that we grew up in. It is now in recent times that it is very much prevalent that you're hearing people are having blood, bone, skin, ear, nose, throat, all different types of cancer. When we were growing up, and I think the young man is the only one here who would say no, but when we were growing up, majority of us, you just have cancer. And as Jamaican as we are, why you look suck out, 2 months later you're dead. Oh, we bury them, move on. And the misdiagnosis of, oh Lord, they look like she have AIDS. You're dead. You're buried, move on. Right? I don't want it to feel like I'm telling a lie, or if I'm incorrect, please correct me. But that's how culture would have pushed itself where we are concerned. So cultural beliefs influence how individuals understand, respond to, and manage illness. And we can see that within our country. Right? So culture refers, and we know already, to shared beliefs, values, and customs that shape behavior and interpretation. It influences how people view disease causes and health practices, and understanding cultures help bridge gaps between patients and healthcare providers. Now, in the beautiful country that we live in, and we are hearing of the marvelous improvements that have been taking place, we still know that there are some spaces which them call back of God, where people don't even know where the nearest health center is, because everything is a bush, yeah? You have a bush for everything. And whatever the ailment is, there is a bush for it. And when they pass away, to God be the glory, 2 scriptures, and they're put in the ground. But so many things could have been done, and they could have lived longer if persons would expand their knowledge of what is being offered in the world. So now, how does cultural beliefs affect illness? Some communities view it as this, a punishment, what we do. And some of survivors will tell you, you know, I thought that I did something wrong. And them start go back into them life. When I did 20, me did thief 2 cow. And when me thief the cow, the man did come and send the message in the community, say, anybody who did thief the cow, they shall live the most painful life until the day then dead. And then few years later, I catch cancer because it looked like it was giving out, so then I catch it. Yes? And now I have to bear that burden. Yes? And it is a curse, right? I did something morally wrong because somebody thieved somebody, man. Okay. Oh, we're waking up now. Alright? So a spiritual or ancestral issue rather than a physical illness. So we know already that we would have spoken about the situation stating that we have heredity. So people will trace back and they said, my mother died from this, my aunt died from this, so it is a familial thing. We need to check it out. Some persons take it a little further. The whole of my family curse from my auntie did do this, or my grandmother did go this, where she never go on from that. This is the problem that is plaguing our family. So by the time each female in the family reaches about X age, we become scared. And by the nodding of the head, I am seeing that we are familiar with these stories. So grandma did this, and then from grandma to great-grandma, or great-grandma to grandma to mommy, then me I worry about my cousin them and all of these people. Because why? Because we believe that it is a spiritual warfare. Yes? And then it's a taboo topic, and because it is so taboo, we don't talk about it. So you see the family up the road, they're sickly. But we don't really go up there. We will say hi from down here, so. But we really don't want to say hi too close because we're afraid if we catch it. Yes? So people are still even off the view, some persons are still even off the view that cancer is catching like HIV. And we have to now ramp up sensitization and education where this is concerned. Right? So we know that these beliefs will lead, or the challenges about these beliefs will lead people to have fear, denial, and the most key part of it, delayed diagnosis. Right? Stigma and silence. Fear of discrimination or social rejection leads some to hide their condition. Now the most beautiful thing which we are realizing is that we're in the age of social media and we're in the age of internet. Yes? And I am not exactly sure at this moment how to take it, because sometimes it looks like we don't have no shame. I will go out there and people are cuss with, and we can say, yeah, me catch this and me catch that and me catch that, and some people can list out on social media the 40 diseases that they have. Yes? But they are also on the different end where people are so ashamed and afraid because I have this debilitating illness. It is affecting me. It is affecting my family. I don't want anyone to know about it. So what do? They hide their respective conditions. So silence and secrecy may result in late stage detection. Yes? You will also have persons going to the hospital and come back and say they feel afraid, they don't want to. They start the process by going to the hospital. They start the process by going to the clinic. But because they already have the feeling in their head of being judged, the security look on them too wrong. A little bit too wrong. Or the security may say, go sit down over there, so. And it moved them from, I need to go check something out, to me now go back there because somebody not have no manners to me. So we start to blame everyone else just to delay going to check out what is wrong with us. Right? And that's why it is good when you have the respective medical teams visit the respective communities so persons feel a little more comfortable within their space to say, I can go down to the clinic, I can go and get checked. And then if something is greater than what can be dealt with at the clinic, you're now referred and say, come directly here. Sometimes that's just what people want to hear. I have a specific person I can go to. I don't want to talk to a security. I don't want to talk to the customer service people because they have no customer service. That's a different topic. Alright? In some cultures, discussing cancer openly is seen as inviting bad luck or shame. So we don't talk about it. Yes, it's taboo. We don't deal with that. So gender and cultural expectations. So gender norms shape health-seeking behavior. And we know already they always state that, unfortunately, sir, we are in the minority because we live less than females because for everything them go like this and them check everything. Them claims that we as males, we don't do that. That's what is said. Yes? And then we take some risk with them not taking. Yes? So they will live a little longer than us based upon what is being said. So women may delay screening due to modesty or fear of being judged, while men may avoid seeking help because illness is perceived as weakness. So all of you females in here who have your respective partner, I hope they take this part out of the television segment, withhold something to tell them to go and check up if they don't want to go and do it. Alright, I'm glad you get that part. So let me go again. Withhold something to let them go and get their checkups. Yes? Because at the end of the day, who will have, well, if you're the true devoted partner, who will have to take care of them? Not me. You can't say you. You, that's me, not you. When you say you mean me. I don't know you like that. Alright. So family roles can determine who makes healthcare decisions. That's the next thing too. We know, and we have been speaking about it from this morning when we speak about the Bible and our faith and our beliefs. We have some cultures where no matter how we live and cleave, and no matter how we marry and move out, and mommy still make decisions of whichever partner. So you left from St. Mary and you went to Westmoreland to live. But every little issue, mother has to make the decision. Am I telling a lie? Or because it was set in the will, and we know so we are wait for them to go quickly, we can't go against the will. The will stipulates that X, Y, and Z must happen. Jesus. Because if we deviate from it, all the money will go to charity. And we don't want that now, do we? We have lived with all the problems all these years. What 2 more years can do? It can help it. So we will live through that pain. Now, these are the things, ladies and gentlemen, when you're going into relationships need to be discussed. Because health is a part of the conversation. Who is responsible for you? Is it me or is it your entire family? What will take place if you end up having a type of cancer? Whose decision is it? And if 90% of the answer surrounds family, you need to have a deep-seated conversation with partner and family, and you have to now start to outline your individual perspective. And if nobody now agree with you, well, I know you're married already, so you all agreed with that. So we can move on, right? So traditional medicine and belief. Many cultures use herbal or spiritual healing before medical care. Right? Now, we know which country we live in. 2 weeks ago, there was a march, and the march from the pastor said, we do not wish to legalize obeism. It is a part of our culture. And being so embedded in our culture, that is a part of the belief. There is a diagnosis, you go to Dr. Cox say, you are at this stage. Dr. Cox, give me a month. We go try something. I soon come back. See him right there, he can agree or disagree with me. Because if it's not Dr. Cox, it's Dr. somebody else. And when they say, give me a month, trust and believe is either 1 or 2 places they're going. They're going to the herbalist or they're going to the scientist. No, sir, we don't call them dog guys, it's the scientists. And when we go to them for the advice, and you shall dip and fall back, and you shall bathe 2 times, and you shall do this, and you shall not bathe for 10 months after that, and you this and that, and this is the result you shall get. When you go back to Dr. Cox, the only thing he can say to you is that I have to cut off everything. When it may have been a possibility when he caught it, it's a possibility he could have just go in, remove that particular tumor. You possibly would have had the breast same way, so you have both of them. But now you have to take off everything because what? He showed you the respective stages. And unfortunately, it is sad to say, but it is also proud to say because of where she is right now. The statistics for 2024, my mother is in it. And my colleague sat there and she asked me the question on the phone, are you good? Just by listening to it. Because I was not supposed to be the presenter here today either. But the person who was supposed to present also is a breast cancer survivor. So everyone has a story to tell. Yes? And when we look on all of these things, our health is very important because we tend to talk about the milk and the honey, and we tend to talk about the hellfire because that's our belief that we grew up in. But I am also of the view that you were told to live your best life because you only have one. Yes? And I am not disreputing anyone's belief, do not get me wrong, but what I want us to understand is that the culture to which we belong to, the more we grow up, the more we recognize that some of the things that we were taught may not necessarily be so correct. So we have to understand what we are going to take and what we are going to deviate from for our health and our self-care. So mixing traditional and modern treatments can create conflicts and confusion. Again, Dr. Cox is here. He can tell you, you cannot be on, what's that liquid there? Chemotherapy. But at the same time, there is about 40 bush you're mixing together to work. Because we have to remember that these things affect your liver, your kidney, your lungs, all of these respective things. Yes? Respectful dialogue between healers and doctors support better outcomes, and now this is where we need to have these conversations. Because if you're stuck in your belief that I know Mass John down the road and he used Cersipina and Cyrilina and all of these bushes and it worked for my aunt and it worked for my auntie, and it worked for all of these people. Dr. Cox and the other doctors that are dealing with this situation need to have a conversation with Mass so-and-so. Because if your belief is still stuck on the Mass so-and-so, Dr. Cox is going to have to allow him to let it ring in your ears that this is the procedure that we need to do, and this is how it is for you to be better. So sometimes doctors, don't fight with them. Tell them to call Mass John. And you will know if Mass John is as illegal as possible, because if Mass John is illegal, him not come. Alright? So communication barriers, we have language and medical terminology may be misunderstood, and we know that for sure. Yes? The learned doctor over here, when he was speaking about treatment, I will tell you no lie, some of the words that he used, I don't understand one of them. But when he said this is a form of pain, I understood that. So that may be one of the things. You use all the big words with them, and then when you finish, you said it means that you have pain in your left foot, down in your ankle they go swell, and all of this, because we know we have the medical terms for that. But you cannot say that to a man who come from deep rural Westmoreland, where I'm daughter convince him to come down to the hospital because he no believe in doctor. Yes? Cultural norms may discourage questioning doctors or disagreeing with them. So we also have cultures when they speak, they said the learned individual has the knowledge, and because they have the knowledge, we are going to just believe in everything that they say. So because of that, they don't question, they don't ask anything. Can I do this? Can I do that? Right? And historical mistrust of healthcare system can reduce treatment compliance. So I don't like nobody at the hospital. And one doctor did kill me auntie in 1975. But here is the thing. Me born in 1995. But because of what continued to be said across generations, I don't trust nobody in that white robe or those scrubs. Because when you kill me auntie, you go kill me too. So we have to bridge that gap. So family and community influence. Family plays a central role in many cultures' decision making, as we had alluded to earlier. Some families choose to conceal a diagnosis from the patient to protect them. So this is now where even family do it. So sometimes it's because mommy or daddy cannot read and something happen and bigger sister go find out. Bigger sister hide the information. Mommy, you're good, man, you're good. Not no wrong, man, and every time they go in and doctor use the words, and then after you go out now, you sit down in there a little more and you talk to doctor and you still not tell mommy or daddy what is really wrong with you. Right? Community opinions can strongly influence treatment choices and emotional support. So the community don't like this hospital in the area and all of this, and because of that, and as was said by Dr. Barnett, because we are influenced to be social beings, we also deal with group cohesion. So because the group says this, we want to ensure that we're a part of the process. All right? So now we're looking at the competence in care, cultural competence. Healthcare providers should learn about patients' cultural values and beliefs, use interpreters and culturally sensitive communication, and please be of the understanding that as much as we are in this one country, we still need interpreters. And I'm not going to knock any parish in here because I don't want nobody beat me, but have you heard how some people speak from the different parishes? And then within the parishes, the subset of words. Now my friend is laughing down there because she knows she pronounced some words. So even that too, you may use your most beautiful English of a language to them. Them just a shake them head and say, But them not understand what you're saying, and that's why it is stated you must be able to read a room. Words tell you yes, body tell you no. Which means that you have to find an appropriate way to explain the process to them. Right? Respect traditional or spiritual practices. You may not agree with it, but it is of your duty to respect it. They know what they went through with their beliefs and how far it brought them. Because you may not believe in it does not mean that it is wrong. Respect it enough, but outline all the possibilities to the individuals out there. And culturally competent care promotes trust and better outcomes. Right? Case example. A Jamaican woman ignores a breast lump, believing it's caused by cold in the breast. There is one main illness that we have as Jamaicans. It starts with a G and it ends with a S. We have gas. Gas is the best disease that we have. Please give me the remedies of how you cure gas. Tea. More specific, what type of tea? Bush tea. No man, be more specific. What type of bush tea? You have mint. You have ginger. You have what lemongrass called? Fever grass. You just need to drink and you need to let it out one of two ways or both. And you're good. And if all of that fails, go sleep. You're trusted to be better when you wake up. And when the pain gone, see it there? I did just gas. It did itch up somewhere and then start identifying you where it did itch up because them and you have the pain. So you did find it up in your neck and you sleep. Alright, where reach now? And they say you're reaching at the root down here. So you just need to drink some tea. No? Soup next. And once it come out there, so you're good. And because of that, ladies and gentlemen, you get late stage diagnosis because you continue feeding on tea, you continue feeding on soup, anything hot to let out the gas. And then when you finally go to the doctor because something happened, you drop down. Doctors, what are the causes for them really to run come to? No, drop down on one of them. What else? Can't breathe. And them never have asthma from them born. So something must be wrong. I must bring you there. What, anything else? Pain. So drop down, can't breathe, or the pain is so excruciating, them tell us that them start to see the light a little. It look faint, but them they see the light. And they bring to the doctor, and the doctor starts saying, okay, I'm seeing symptoms of this, that, and that. And so how long have you started to having these respective pains, this feeling, you're looking flush, all of this? And they start telling us from last year, January. I know you're going to say, oh, well, you know, I'm sorry to say you have stage 4 cancer. Because you sat there and you waited and you waited. Please remember, ladies and gentlemen, if you don't take anything from what I say to you this evening, understand that your body speaks to you. And if I'm telling a lie, you have one table over there, so of all the colleagues and friends who sit together, who can shake their head in agreement, your body speaks to you. And when it speaks to you, it's telling you that something is wrong. Which means that you need to go and check it out. Right? So, the lesson here, health education must respect cultural understanding while promoting early screening. As what my colleagues said before me, the Ministry of Health and Wellness have been pushing over the years education, where people need to go and do their respective screening, and they're not speaking about females only, they're speaking about everyone. They have made certain things available, like the National Health Card, NHF, National Health Fund Card. It is now beautiful where everyone can sign up for it. You just know that the more conditions you have, it helps, more coverage you get. But down to the children can have it. They are becoming more accessible and more reasonable health insurance out there. Why are you paying health insurance every month, or the space that you work are paying it every month, and you have the card that look on it so pretty? Why it never come out of the wrapper yet? But you have pain in here, and around there. You're paying for it. Go and use it up. Yes? The role of health education, it's designed culturally appropriate awareness campaign. We have that. I have seen it. Yes? Partner with community leaders, faith groups, and local healers. And no, I'm not sure about the local healers part, but I know for sure that I have seen, especially in my community, I've seen the healthcare workers out there. Now, I guess this is the part, now doctors, probably this is something that needs to be done when we go to them other people here and we start to them, say, look here, we understand some people are coming to, you know, we're not trying to take away no livelihood, take away no money, but some of these people do need to, you understand? They do need to get these forms of treatment, because you might give them 2 soursop leaf and Them feel good because belief kills and belief cures. But 2 weeks later, them will come back to you again. We know, say, it might stop your food a little, but we do need you to understand that these persons need to live a longer life. Because it's their belief, you know, and trust me, they not stop go there. But let me help them with this part so that money tree does not dry up. You see how we help each other right there, sir? Me keep them alive longer so they can eat their neighbor more. Am I telling a lie? Alright, so promote open conversations and normalize cancer screening. As much as how we have reached a far way, we still as a nation need to do better where it is concerning. So now I'm hearing, I think it was last week, I'm hearing that there is now a less, what's the word I'm looking for? There's an easier way to do mammograms rather than going there, because I know a lot of females complain, so then by the time them going there, them poor little nipple purse out. And we know some of the boyfriends are very upset when they purse out. We know that. So doctors are now saying that there are better ways to get it done. So please, go and check it out. If you have done your check, every female that you know, because the biggest advertisement is your mouth. The biggest advertisement is your mouth, especially if them look up to you. Yes? So, global perspective, belief differ from, and we know this already, African, Caribbean, Asian, and indigenous communities, we all have different beliefs as it is relating to illnesses, right? But we have a common theme. Cultural interpretation affects access, treatment, and outcomes. How is that relevant? This morning it was spoken, and remind me again, the longer your pocket, the longer you live. That's what was said, yes? The longer your pocket, the longer you live. So we are aware of that. Right? Global health must integrate cultural perspective into cancer strategies. How do we move forward? Promote cultural humility among health professionals. Encourage community-based education and screening programs. Support cross-cultural support and patient-centered communication, right? Cultural beliefs deeply shape the cancer experience, and we have heard it. I am not making it up, ladies and gentlemen. All the persons who sat in here, they would have made the indication to say if it was not for them and God. That's their cultural belief. That's their religious belief. If it wasn't for them and God, if it wasn't for a particular Bible scripture, they don't know how they would have made it through. So we have seen it there already. Cultural beliefs deeply shape the cancer experience. It either can make it a good one or a bad one. Respect for cultural diversity leads to better trust and care outcomes. I know we get frustrated sometimes at the hospitals, where as healthcare professionals, people come and they start telling us that they mix goat doodoo and mud, and because somebody told them that, and trust and believe. I have heard it. I have heard it. No, we are laughing about that true. It is very true. And they do all of these mixing concoctions, and then when the person reach into shock, no, that's when the doctors have to deal with it. And when the doctors now have to deal with it, they get frustrated because they're saying, why when this happened you reached to me? Why you couldn't come to me from before? But again, their cultural experience is telling them that this is the way to go. And understanding culture is not a barrier to care, it is the bridge to healing. Ladies and gentlemen, I know that we are ready to go home. I thank you very much for your time in listening to me, and be blessed.
And after that, there's only one thing that Mr. Dunbar didn't do. I am giving you a warning. for the pencil, I was looking for the ruler, I was looking for every single thing. But you did a very good presentation. It was engaging, and me catch a little bit scared. So if I know of any obia man around me personally, I would tell him, say, if you tell the patients, then say they come to you. Oh, not you, okay, okay. Do you have any questions, ladies and gentlemen, for Mr. Dunbar? All right, so there's a question at the back. So you can take.
Hi everyone. Doc, while we speak of encouraging, I'm going to thank you, just give me 4 more years. Thanks. We have ourselves, I don't know what is going to happen. So while we talk about screening and encouraging screening amongst ourselves, I have experienced challenges with some medical practitioners. I have doctors who constantly fussy because, first of all, I do have health insurance, thank God for NWC, but when I go to them and I say that rather than doing this clinically, where you give me a prescription and go take 2 pills, I would love to know if something else is happening there. I would imagine that I have experienced pushbacks to the point where I had an ovarian cyst and I was being treated for gas because, yes, historically I had terrible digestive issues, but in that instance, even after taking the medication, changing the diet, eating properly and on time, I was still having the issue. And I had to drop down. So when I said that, I came over here about the drop down part because in reality, that's exactly what took place. I had to feed my children, run for neighbors and the lovers. And it was discovered after ultrasound that there was something else there. So even from the medical field, sometimes as patients, we do get these pushbacks. Is there something that we can say an awareness program even takes place that targets our traditional doctors who may not be so inclined with all the testings that we're now being seen in the medical field? Is there something that's targeting them as much as it's targeting us as potential patients?
Okay, so I have to start with the first part of it to say, like every profession there is, we live the experience sometime, understand the experience, and then correct the experience. So in everything we do, we live, we make errors, but it is how we correct those errors. So understandably, you would have said that you would have got pushback and so forth. It is hoped that from that time to know that clinician would have corrected the stance in how to assist the process moving forward. The other part of it too is that as we would have stated, the Ministry of Health would have started its campaign. Based upon your question, it means that you would need some other things to be added to it, which for me, I don't think as a nation anyone would disagree with anything there. But I personal, and this is my personal belief, because many times these things start from the mental challenges. Sometimes we need to start to marry them. Mental health, physical health, all of them together.
Social health.
So if we're in, and start granular. So if we're having persons who are going to do the sensitizations, let it not just be the doctors only going out there, but you have, as Dr. Barnett would have already stated also, you have a social worker with you, you have a psychologist with you, because sometimes symptoms mimic other things. And what may be thought to be one problem, sometimes it may be another problem. But I personally believe that the sensitizations need to be a little more granular. we need to go into some of these spaces, because now that we have become so digitized, many people have moved away from TVJ, many people have moved away from CBN, many people would have moved away from the traditional radio, and we know that internet has the wide possibilities. You can't reach out to everyone via that medium. So if we can go into spaces and say, all right, we're going to tackle this community this month, this community this month, this area, we realize, because the medical field have their particular reports as to what's taking place within specific areas, and say, all right, we may need to go there in person, we may need to deal with this, we may need to call out the leaders, have them, put people in the community center, we go and talk to them. We realize that that's not working, we try to go house to house. One thing I realize people don't run away from is when doctors come in and they community. Doctors, you can correct me if I'm wrong, but I don't, because as them, Miss may have a problem here, so. Miss may have a, doctor, I want to tell you I have one sore and I feel like it a fester, and the first question you may ask is, so why didn't you go to the clinic? The clinic too far, I mean I have no money, but now you're there, can you just dry out for me now? You understand what I'm saying? Yes. So if that is the case, then we have to, but again, we have to start the process. The community that you live in, you may have to start the process to say, listen, I'm writing this letter to the clinic, reach out to the respective persons within the parish or within that particular district. We need these people in the spaces to assist so we cannot misdiagnose. I do hope I have answered your question. Anyone else?
Alright, so I just want to add something to what you said. You mentioned mental health and physical health, that we need to take care of that. But I also want to add to that we also need to take care of our social health. Because the truth is, many times our mental health is a result of the fact that we have isolated ourselves from everything and everyone. And then when we do not have anybody to be there to help, to support us, then we even go into further depression. So we also need to ensure that when we not see the neighbor for 2 days, we check up on them. You understand me? So we do that. One more question? Alright, so we take one more question and then we head into our final.
Another part of the cancer journey is the impact of your medication. I suffered with gross hallucinations when I was going through my treatment, and without the support of a strong support group, it would have been very challenging. And being out there on the field with our outreach work, we find a lot of persons who are in the workplace and they struggle because they don't want people to know that they have a diagnosis. Because of, I remember I had one lady who said she couldn't tell anybody about her diagnosis because she had ovarian cancer, and it was believed that it's because you're promiscuous why you get ovarian cancer. And there are a lot of beliefs along that line. And just having the illness on its own can have a lot of psychological impact. And again, I'm going to go back to the system in terms of what is in place to support people like that. Also, the vaccination, the medication, maybe the psychological care, and how we look after our mental health whilst we're going through the journey.
All right, so one of the things I have, well, not me alone realizing it, but let's be very frank where this is concerned. You mentioned psychologists on the left. The response is mad.
Yes, get you.
You mentioned counseling. The response is
depressed.
Me no mad. What we are happy for is that post-COVID, people are now buying into the fact that we need help as individuals and as groups. being specific to respective illnesses and so forth, one of the things since I became chair of the Western Region for Jamaica Psychological Society is that I have been pushing, especially this month, which is Mental Health Month. We are not trying to be specific to any one group or one person. I say to persons, I throw it out there, I said we have a group of psychologists which are ready and available to, one, do presentations to you to sensitize and educate you on the respective things which are going on. Two, if it is the case that you do need counseling, let's not talk pocket at the moment. Let us see how best we can help. Even if it is the case to do a basic screener to see what exactly is going on with you, we start that process free. Yes? The third thing too is we want people to understand that we are here, and a part of being here is seminars like these, where we come out and we let you know that you have the challenges, you went through surgery, you do not have the respective support and so forth. We are here to assist you, non-judgmental. Yes? Because as you would have recognized before you talk about title, we're dealing with human beings, and everyone is a human being before a title is bestowed. And everyone, if it did not affect you personally, you have someone who is affected, and as such, we have to ensure that we are giving that helping hand. So, for the month of October, for the month of November, for all the months there are, we are available. Again, we are not being specific to anyone. So if you want to call us and say you want to do a presentation, because you know that some persons are facing these, we want the entire office to be here, because we're not singling anyone out. Why? Because when everyone recognizes that we have the support around us, they feel more comfortable at some point, maybe not in the moment, but later on, to share, to reach out. So we like to do it that way, where we come, we have the conversations, and then from there, you can decide, do you want us now to speak with you individually? Do you want a smaller group? And we take it from there. But mental health is real, mental illness is real, but the power is in your hands, ladies and gentlemen. And the doctors may be here, but you have colleagues who are the worst patients also. Yes? I remember going to one particular doctor, and I sat in front of the man, and when I looked into the garbage bin, there's about 12 cigarettes and 3 bottles of Pepsi on the table, and the man had the nerve to tell me, don't drink Pepsi. And I never understood that. And not as I do. You understand? But thank God I don't drink Pepsi. So, but the seriousness of it is, as the question is being asked, the only person who can start the journey is you. Because here is the thing. You may sit in here and you may look as beautiful as possible.
True.
But you may be having other problems than what we're even talking about here today.
So true.
You see that money financial bag there? Everybody inside here has it. Some way or the other. And then the domino effect leads that it now starts to affect something else and something else and something else. So we are here for you. Just let us know. All right?
Thank you so very much, Mr. Dunbar. Ladies and gentlemen. So we have one final testimony. And so for this time, I'm going to invite to stand with me, next to me, Debbie Waters. Ms. Waters, you want to walk with the microphone at the same time?
Good evening, everyone. I'm okay.
Good. So you want to tell us how long
Okay, I have been diagnosed about 8 months now.
So 8 months. How has the journey been for you?
Well, at times it has been rough, but I put my trust in the Almighty Father because if it wasn't, if it hadn't been for him, I would not be here, and I would not have found out about it before it has spread.
So you have support around you? Who's your main support?
My children.
So your children. How? So we oftentimes talk about the journey of the patient, but we've never ever spoken about the journey of the caregiver. How do they feel about you having cancer?
Well, at times it has been rough. At the moment, I'm just living with my last child, and at times can be really frustrating because at times he's sad, and you know, when I think about it, I get frustrated to know that he is the only one that is there with me now, and he's, you know, encountering everything that I'm going through.
How old is he?
He's 13.
He's 13, sorry. 13 is journeying this walk with you. And you are there obviously for him because he was a spirit. How has this affected the quality of the work that he produces at school? We'll have a conversation. I'm a teacher, so I want to learn.
Well, at the moment, when I got his results, I wasn't pleased, but when I think about what he is going through, you know, to face everything that I'm going through, to look and, you know, to see what mommy is going through at times, you know, at times I get hungry at him, at times he gets hungry as well, and it is very frustrating. So, his grade is not good, but I'm working with him as a single parent. I'm working with him I'm doing my best and just in the Lord.
As I come over for the Mistyblue Foundation, then we will not only be helping you through it, but we also have to help him through it. And so it's a community, ladies and gentlemen. When we come to sessions like these, we have to ensure that we look out for every single person. And so I can just imagine the pain and the pressures that he feels having to care for his mother as a 13-year-old, but goes into a classroom where a teacher wants him to score 100%. And that pressure be placed on him to get that grade, and if he doesn't get it, all the other things that happen. And so as a community, we're not just talking about one person, we're not just talking about the patient. We're not talking about the fighter or the survivor, because the truth is there's a fighter and a survivor in each of us as we continue to support the person whom it is that we love. So I ask, ladies and gentlemen, that as we leave from here, not in this present moment as I'm speaking, but we think about all the other persons, because for me, I now have a renewed vision to ensure that the students that come to me, I take a vested interest in knowing what is happening in their lives. Because I can just imagine how easy it is for a 13-year-old to just go through it and don't even speak about it. But if you really don't know, or if you don't take the interest to care, then something else will happen. So I encourage you, mommy, continue to fight. It's not easy. Come, sonny. It's not easy. We're here for you. Continue to be a good support to mommy. And wherever it is that you need the help is always there. And she's right there. Put your hands together, ladies and gentlemen, for every white house actually fight this good fight. And so, we have listened. We have heard from doctors. We have heard from survivors. We've read the room, we've observed. And for one thing we're sure, there's not enough money. And so the truth is, if we don't make plans, whether it is that we are yet diagnosed or not, then we can be taken off course. And so one of our sponsors for this event is Scotia Bank Insurance. And so we're going to invite them to come to share with each of us here the possibilities that we can engage in to ensure that we take care of our lives. We can put away just a little, just for that day. We never know when the day will be or who it will be, but we too can make preparation for any day to come.
Good afternoon, everyone. It is truly a privilege to join you at this Faith Gifford Breast Cancer Symposium. On behalf of Scotia Insurance, which is a subsidiary of the Scotiabank Group, I extend sincere gratitude and appreciation to the Mistyblue Cancer Care Foundation and its remarkable chair, may start this section. Let's give her a warm. Your passion and your persistence really continues to inspire not just those in Westmoreland, but across Jamaica. You know, but we were just talking about your foundation when you called the other day, as I mentioned. So continue to do the great work that you're doing. To the medical experts, presenters, survivors, caregivers, and sponsors, your contributions make this symposium a source of strength and learning for so many families. So we're very honored to support this mission. Our team members at the back, Ms. Garwood, Ms. Burnett, and all the others across the branches and at our head office is always standing ready to provide advice and solutions to our clients. And as a tangible expression of our support, we pledged 15 mammograms, and we also donated 20 mammograms during this month as well across our branch network. It's important that women in particular access early screening because prevention and early detection save lives. During this month, when we shine the spotlight on breast cancer awareness, Scotia Insurance is doing our part with a campaign dubbed Pink Without Prejudice. We have Pink Power Days, information on our social media channels, in the press, branch executions. We have a vigil coming up and our staff mobilized to support the fight against breast cancer. At Scotia Insurance, we believe that being here for every future means showing up not only in the good times, like get to buy your house and car and all of that, but also in the most challenging ones when life takes an unexpected turn, such as a cancer diagnosis. Our Scotia Criticare plan is designed to help. It provides a lump sum payment upon diagnosis of a confirmed critical illness, such as cancer, breast cancer, and it gives individuals the financial stability to focus on treatment, recovery, or simply maintaining their mental health during a difficult period of time. You know, we always often tell our clients that sometimes it's not the illness that you know, really breaks you down, but the preparation, where the money coming from. And so this lump sum will help you to be able to focus on recovery. So this is how we stand by our clients, helping them prepare, protect, and move forward with confidence. So as we reflect today, let us remember that health and financial wellness go hand in hand. Together with advocates like Mistyblue Cancer Care Foundation, the medical community, and committed partners, we can build a Jamaica where every person has both care and coverage to face tomorrow with hope. Thank you, and may we continue to walk together in faith, compassion, grace, and strength.
Thank you so very much. Scotia Insurance. And here we talk about the lump sum. So a lot of money if you put it down little by little. Ladies and gentlemen, you have been a most wonderful audience. Put your hands together for yourselves. But it is not my closing remarks. At this time, I'm going to invite the chair of the Mistyblue Cancer Foundation, Ms. Dorothy Satchwell, to come, and she'll be doing our reflections and projections. Put your hands together and make her welcome.
Thank you, sir. Me again. It was the year 2018. It was during winter. I was in England, and I got a phone call from my sister. And she said, I just want to tell you something. I have cancer. And she hung up the phone. I never did anything about it because I never believed. I just thought she was just making a nasty joke. But she did have cancer. And for a moment, what I thought was that my maternal grandmother had died from breast cancer. And now my sister had breast cancer. So I became very selfish and said, is me next? And the following day, I went to the doctor, had a conversation with him about it, and I was signed up to start having my mammogram. 3 years later, I had breast cancer. And most of you may know me that I talk a lot, and I will argue with a lamppost. So I started deliberating with God to let him know that this was one time he made a mistake. Because if I had cancer, it meant that I was going to die. Because number one, I'm a lupus patient, I have asthma, I'm arthritic, I'm rheumatic, and I have Raynaud's. I have hypertension. Yeah. So you tell me how I'm supposed to have that and have cancer and survive. But me never part today. Because not only for me, but I had a son, and I know that he needed me. Probably I needed him more than how he needed me. And therefore, I had this long argument with God as to why he had to change it, make something else happen. And I wouldn't go to the doctor because I was giving God time to change his mind. Because a confirmation of a diagnosis would mean a confirmation that I was going to die. But God being God, put me on my Damascus experience. It was about 2 o'clock one morning that I was woken from my sleep with burning sensation in my chest right here. And I'm paying no mind on because it's not supposed to happen. And then for once, I decided I was going to be obedient. I said, okay, God, may we obey and go, doctor, on one condition. You are going to spare my life. But you must put challenge to God unless you are prepared to fight the fight. If you think of any possible negative side effects that somebody can have from cancer and cancer treatment adversely, I mean that. I had it all, the full Monty, I had it. I had several surgeries, I had chemo, I had radiotherapy, I had hormone treatment. But in the midst of all of that, I'm allergic to most anesthetic drug. And the only painkiller I can take is paracetamol. So I'm no doctor's friend. So that was a challenge that I have. I did a mastectomy, and then when I took off the first breast, they had put the offer on the table for me to do clearance. But I said, I need to do clearance because 3 months ago, I did mammogram and I was all right, which means that it's just in the beginning stage of the cancer. So just pluck it out and all will be well. I had stage 3C. And it was a journey. During my treatment, I lost my sight, I lost my hearing, I lost complete mobility, I lost use of my bowel and my bladder, and I lost my eye. Because me did say, me a big woman, nobody now beat me, nobody now wear me back, nobody now have me hepatitis. Yes, and I was brought down to, I said, God, I must have done something, or somebody now may have done something, because it's big, not true. And I only could package, and I never understood why, but there were times along the way that I felt like, I got suicidal, I had a lot of hallucination because of the amount of steroids that I was on, but what I had was a fantastic medical team, support, all the way there. Family, church, friends, enough. So I had friends globally. And what I did, we created a chat, a group chat, so that everybody could communicate with me without me having a problem with me being in England, you in Jamaica, somebody is in America, somebody is in Canada. And every time before I have an appointment, somebody remind me, say, remember tomorrow is your appointment at 10 o'clock, make sure you go on time, all of that, and stuff like that, you know. And one of the significant things from a religious perspective that stands out in my mind, I remember there was one night, on the eyelash that hurt me. And I was there in the bed, and I looked at the cup with the water. And you ever thirsty yet? But I could not move a muscle in my body to take up that cup because the pain was excruciating. And the phone rang, and the phone was right beside the cup. Me don't remember what the phone answered, but I remember the phone ended up on the bed. And I heard somebody started to pray. I recognized the voice, but if she said head, the pain went. And if she said neck, until she reached at my foot. I was never so exhausted in my life. When I woke up the next morning, I called Valerie here in Jamaica, and I said, Valerie, you have a dream last night, you see? And I told her about my dream. She said, you're lucky you dreamed it, I lived it. I said, oh, you mean? She said, well, I was in Kingston, and I had an earthquake. My bed started to shake. And the voice said, get up and pray for Dorothy. She said, last night I rescued you from the arms of death because it was there for you. She said, when I was finished, every piece of garment that I had on was soaking wet. My bed was wet. But you are alive this morning, so purpose fulfilled. That is one of many of the experiences that I had. The other one that stands out in my mind was my son. When I had he went to all of the appointments with me before I had my first surgery. I had surgery Thursday, and he had his first university exam on Monday. He failed every subject. Maybe it's not a failure. So thereafter, he saw himself as a failure. Went into depression. We wouldn't go back to school because I'm a failure. And then I had to leave because he can't keep living with that mindset. He stopped coming to look for me when I started to do chemo because my body did not work. And then it was my birthday in December, and he came home. And my son is a musician, and he always tried to teach me to play the piano. But he said I banged the keys and they are supposed to be caressed. But I heard him in his room banging the keyboard, so I know something was wrong. And he came into my room in the night, and he sat on my bed and I could feel the bed shaking. And he said, "Why don't you just die?" My child didn't want me to die. He said, "I can't do this no longer, Mom. I can't answer my phone, I can't go to class, I can't go with my friends because my phone is going to ring and somebody's going to tell me that you're dead. And I just wanted to just die right now and get over with it." And I hugged him and I said, "I love you." And that was 14 years, 10 months, and 2 weeks ago. And then I ended up in palliative care when I was in hospice. And they said there was nothing further that they could do for me medically. And they wanted to call my family in to talk about it. And they said, "What about?" They said, "Oh, it's difficult, you don't have to do it, we can make the phone call for you." And they said, "No, we don't afraid, we just don't want to make no phone call for me, because we ain't going nowhere." And I remember the last time when they took me out of, because I had left hospice and I had gone to the hospital, and they took me out home. And the night when they were leaving, they asked me to leave the door open so they can have access tomorrow morning. So you know what I do? Well, when they came tomorrow morning, I was in the kitchen making juice. And I was the one who looked scared, he was. And that was when gratitude started. Because I know doctors don't really, well, then said the doctors behave like they're gods. And I remember my breast surgeon said to me, "Dorothy, I have no medical or scientific reason to give you today why you're alive. Because on paper, you're a dead woman. I don't know what it is, but whatever it is, enjoy it." But I knew what it was. And it is that reason why the foundation started. Having been with the foundation for the last 10 years, the symposium here today symbolizes what we started off in terms of our intention and what we want to do, where we want to go. A part of my survivorship has a lot to do with the quality medical care that I got. I also had Macmillan Cancer Support. Any type of support that existed in England, financial support for cancer people, needed get it. We never do nothing, Macmillan did it. And that is why I believe in what support groups can do. You had Red Cross of England. Any week, every week that the garbage truck was going to come, they empty my garbage, they clean my house, my clothes was clean, supermarket was done, market was done, because I couldn't do it. But they were able to do it. There was Firefly that was started by somebody who had cancer. When I was to the radiation, every morning they'll come pick me up. I couldn't walk, so they lift me up, put me in the vehicle, carry me back doctor, carry me back home from start to finish. There was another cancer support group. Every Wednesday before I had chemotherapy, they would take me, they would give me massage therapy, they would give me hydrotherapy, any therapy I thought I needed, they gave it to me. And I sat and I thought about how all those different support groups, along with my medical team, enabled me to survive. And I don't want to believe that is because I was in England, it happened. It happened because people were behind it. The same people then with the mindset that they have in England, we have it here. of Jamaica also contributed to sponsoring us to be here today. RPL, Scotia Insurance, and other entities enabled us to be here today. What I would love is that you have individuals, you have corporate entities who can do more. I have had a conversation with entities that said, cancer doesn't have anything to do with us. You're here from the hospital, you fall under the arm of government. You're here from insurance company, you're here from Red Cross, you're here as part of Faith's family, and you have so many entities that are represented here. But there's one common thing among all of us. We're all in the parish of Westmoreland. And all of us are being serviced, our agencies are being serviced by our people. And none of us is immune to cancer. None. And therefore, my appeal today is that we take the information that was given here today and we go back to our respective homes and entities and don't sit down on it. Yes, our government has a responsibility to provide, but we cannot keep talking about what our country can do for us and what our government can do for us until we are prepared to do something for ourselves. Faith did her bit while we are here. And the foundation is in the parish for 10 years. And I still go on the road and so many people that they have never heard about it. And we are still at that place where we think that cancer is something that we friend have, we neighbor have. Oh, one lady at the workplace have it. You know, like how white people say, oh, I have a black friend or I have a black co-worker. We tend to look at cancer that way because it is something that other people have. Every time that somebody at the hospital gets a diagnosis, one of your co-workers, it affects all of you. And every time that somebody at your church gets a diagnosis, it's not the individual who is diagnosed, but all of the diagnosis. And therefore, we have to be united in our efforts to beat cancer. In the year 2023, 1,350 people in Westmoreland died from cancer. 27 of them was breast cancer. And it may sound like not enough, but it is 27 families, 27 homes that lost a loved one to breast cancer. And we have to get to that place where you and I realize that we all have a part to play. We have a responsibility. Debbie came up here and she spoke about her journey. It was because of the effort of the foundation, Debbie did a mammogram. And from that, she found out that she had cancer. You have so many other persons in the parish who it was because of the health fears that we have, whether it's breast cancer, prostate cancer, or some other cancer, we were able to impact lives, but I am sure that we can do so much more. For this year, Sandals Foundation sponsored 50 mammograms. American Friends of Jamaica sponsored 50 mammograms. Scotia Insurance committed to do 15 mammograms. But guess what? Out of that 115 mammograms, 2 persons did theirs, and one machine that was working in Western Jamaica broke down. And that is our reality. So even though we tried and we were able to secure sponsorship for 115, and trust me, if we did get 300, it would have gone just the same. The dream, the vision that we have is that next October in Westmoreland, we need to have a mobile mammogram for our parish. It can happen, but it has to be something that all of us are committed to.
ourselves, what can we do? And sometimes it's not because your pocket going to be long, but sometimes it's because of where your voice is and who you can speak with. And we have to understand that together we can achieve so much more. And at this time, I'm going to stop. I'm going to say to Dr. Cox, take the mic and what we want to do, because what we have in mind is a Faith Gifford breast cancer fund that we want to launch today. Dr. Cox will explain to you what is it we want to do with that fund and how we hope that that can help Westmoreland in terms of breast cancer, and that Faith legacy can live on one way or the other, because she was a phenomenal woman. And I thank you all for coming here today and for sharing with us. God bless you.
Well, as Dr. Roberts had put it, that affluent countries, people live longer, and they do better at chronic and malignant diseases. And in our experience, we know the challenges associated with our patients that come to our clinic. The Mistyblue Cancer Care Foundation tried to raise funds and get donations for a number of patients. Whenever we have prostate PSA testing, or we have mammograms and so on, we generally send them to me to look at the results. However, we need more clinicians involved in that kind of volunteer work to manage some of these mass screening tests that we do. But we know the challenges associated with even getting radiological investigations and biopsies and so on in many of our patients, and that the patients end up having to go and pay for it. Sometimes the cost is just something that will stop them in the tracks and they will not go and get it. So if we send a patient for an investigation and they don't have the money, they don't have the bus fare sometimes to even go home. Sometimes we send them to Cornwall for oncology, and you can't find the taxi fare or bus fare to get there. And it's a real situation. And so we think on this inaugural Faith Gifford Symposium that we will launch the Faith Gifford Trust Fund. And we hope to set up a committee that will manage this fund and sometimes to help our patients who have these challenges in seeking help with their diagnosis. We will eventually get information out about the trust fund and how they donate to the trust fund. We will, because it's modeled after faith, we certainly will start initially by looking for patients who have breast cancer and need help with taking care of the various monetary things that they have to do. And so I think part of our program is today is for members here, and those who are here will take it out for us to get some commitments with the Faith Gifford Trust Fund, so that we can better help a lot of these patients that we have that are struggling with the management of their breast cancer diagnosis.
And as we've reflected, as we've listened, ladies and gentlemen, there are stories. There are stories told here today, and there are stories that have not yet been told. Many of us sitting here, or even standing in my position, have a story to tell. It might not be our story, it could be the story of our neighbor. And we too can understand that if they had the financial need even to do a test, then their lives would have been different today. Dorothy spoke of her 14 years, 8 months, and 2 weeks. Our survivors have spoken about their 12 years, They're 6 years, they're 4 years, they're 5 months, they're 8 months. I can speak about my sister, even though it's not breast cancer. But I'll just share this. I migrated to Canada and I came back to Jamaica for 2 weeks. On August 26, when I came back, I texted my sister to say, I am here, I will soon see you. But that was the day. On the 26th of April, she fainted at home and went into the hospital. On the 27th day of April 2024, I went to the Savannah Public General Hospital and I visited her. I've never seen Canada again. I vowed that I would never leave the side of my sister. On August 11th of this year, I watched her take her final breath. On the 20th of September, we buried her. I know what it is like to be by the side of a person who suffers with cancer. So everything that was spoken about her is something that I personally, I can tell you of the nights when she called me in at 1 a.m. asking me to rub her pain. Because at that point in time, morphine could not have done anything for her. And when I massaged those pain points, she would say, go sleep. You have work in the morning. And I said to her, I will not leave you by your bedside. So I know. But there are many persons who may not have that experience. There are many persons who will not make the sacrifice that I made, because she said to me, don't go back. And I said to her, no. I could not live with myself being in Canada and hear that I need to hurry and come. And so I am making a special appeal to those of us who are here. There's something that I've lived, that what God blesses us with is not to bless ourselves, but to bless others. And so in order for the Faith Gifford Trust Fund to be launched, what does it need? No man, you're going like you not hear me now. What does it need? It needs money. And the truth is, it can only be launched in real terms if all of us who are here make a special commitment and a special pledge to put something in the fund. I speak to your heart. I speak to your mind. I speak to your soul in your body. I'm choosing not to speak to conscience, but I can tell you, one more person in Westmoreland, let it be because of you. It might be your neighbor. It might be your friend. You will never know. It might be you. And so I encourage you, ladies and gentlemen, that today, make it your pledge, make it your plea. Through the Mistyblue Cancer Care Foundation, having listened to Dorothy's own experience, to commit, to put in something worthwhile in the Faith Gifford Trust Fund. You may not have money today, and I'm not going to ask you to, but if it's your desire to support, just raise your hand. Thank you so very much. And so as soon as Dr. Cox would have given the, no, let me take her card, let me tell her the card. Let me tell her the card. So me not have your name, but but heaven has taken record. And so I'm asking you, as soon as Dr. Cox has set up and would have shared, may we put something in. May we help one person to reach the goal of being a survivor. And so at this time, ladies and gentlemen, it's my delight and pleasure to say thanks to you for joining us right here at Sandals South Coast. We want to say special thanks to the organizers for this magnificent function. Put your hands together again for them. We want to say special thanks to the medical team that presented the information. Put your hands together for them. We want to say special thanks to the survivors who shared their testimony. Put your hands together for them. We want to say thanks to JIS for joining us and ensuring that we're going to be on TV. So thank you very much, JIS and the team. Thanks to Sandals South Coast for all that we had to eat. Good food, don't it? So if it says good food, say amen. Amen. And guess what happened? On the end of this segment, there's still more food on the outside for us to eat. We want to thank all the other sponsors. We want to thank Scotia Insurance, AFJ, RPL Grace, Germax Pharmacy, Carl's Pharmacy, for buying into this initiative. The Faith Gifford Breast Cancer Symposium. We joined together, united. We shared our stories, which were unique. And so, ladies and gentlemen, all right. So after Dr. Cox makes his presentation, it was truly an honor being your host. I'm Antoine Hardy, and I will see you next year.
So I'm just making a presentation to the person who sometimes makes so many phone calls to me and I don't answer. No. And then she texts a WhatsApp and she'll say, the noose is around my neck. Walls are closing in. I don't think I can manage this anymore. And I can't respond really. The honest truth is that I'm overwhelmed on one side. And though the concept of Faith Gifford Breast Cancer Symposium was mine, and Faith was, my patient, and I discussed this with Dorothy, and I know that she's like a steam train. There is nothing that will stop her from getting things done. However, she will just say these little guilt trips when the wheels are coming off at times. And so, on behalf of myself, and all the time I ignore her, I just want to let you tell her that I appreciate the hard work that she has done, the tireless, the nights, sometimes she said she just have to escape. She said, I'm not here this week. I said, okay. But on behalf of all of us, we would like to present to Dorothy this gift, this token, for all the hard work that she has done in getting this symposium done. Because it's almost a solo.
2x4. Thank you very much. You're a trickster. It have weight. It's greatly appreciated. Thank you. God bless.
So ladies and gentlemen, what would live good love? We have some things for you to have on the outside. Please take your photo opportunities if you wish to do so. And may God continue to bless you.
Just one minute.